Good morning, everyone. And welcome to day 3 of the One Health Summer Course 2026. How are you feeling today? How are you feeling today for the last day of our learning session in this room? Excited? So I hope everyone still had the same energy as day 1 and ready to push for today's learning and discussion. So for today, we had the last 2 units to learn in this room. For this morning session, we will broaden our lens even further as we focus on environmental and integrated surveillance system. In this room, we already have our outstanding speakers from Universitas Gadjah Mada, and soon will be joining with us from Taipei Medical University, Taiwan. I would like to remind you that there will be a 20-minute Q&A session for each topic. For participants who are joining us online, please submit your question in the chat box via Zoom. Without further ado, let us begin our morning session that will be led by our 5th moderator for the next 3.5 hours with Dr. Farah Yuliani, Master of Science, Doctor of Philosophy. Please show us Dr. Farah's resume. A brief introduction about Dr. Farah. She is a head of the Master's Program in Tropical Medicine, Universitas Gadjah Mada. She is also a lecturer at the Department of Pharmacology and Therapy, Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada. And she is also a researcher in the drug development, molecular pharmacology, cyanotransduction, and tropical medicine. Everyone, please join me in welcome Dr. Farah.
Thank you. for your very kind introduction. Good morning. Are you still have an energy today? Yes, because this is our last day lectures. Yeah, I hope you are still in us, and then tomorrow we will be maybe the happy days. Yeah, there are 2 field trips, and then I hope you enjoy the 2 days field trip. Yes, and then in the end of our summer course, we'll be more excited. Thank you very much. Yeah, this is because I also handle the summer course, so there is some spill the tea of our activities. So good morning, our distinguished speaker, Dr. Daniel. Thank you very much for your willingness to share your expertise, yeah, for our participants. And I would like to say hi online. Yeah, there are also the participant online. I hope you are also with us today. And then for today's sessions, we explore this topic for 3 complementary perspectives, yeah, environmental surveillance, and then the health impacts on environment pollutions that will be guided by Professor Chuang that will later join us, and the health impacts on, data integration with the One Health framework. And for the first speaker, let us begin with our first speaker. It's my pleasure to introduce Dr. Daniel. Yes? Okay. Yeah, we can see here Dr. Daniel. So let me introduce him. Dr. Daniel is lecturer in environmental health and the Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada, and his work focuses on water, sanitation, hygiene, and environmental surveillance. He is also actively involved in national and international environmental health organizations and serves on the expert committee to environmental health issues in the Indonesian Ministry of Health. And today he will present environmental surveillance, water, waste, and vectors. Dr. Dani, the floor is yours.
Check. Okay, thank you, Dr. Farah, for the introductions. And yeah, good morning. Nice to meet you all here. And I know some students here. They also attended my courses in environmental health. So maybe some of the materials you know already. But for most of you, I hope this can refresh you a bit about the concept of environmental surveillance. As introduced before, that my expertise is actually water and sanitation and hygiene. So I will more focus on that. But yeah, I had some projects on solid waste, but not many. So, but if you have any questions, feel free to ask, and we will discuss it directly. So yeah, and because I think I have 40 minutes, right? Yes. Okay. Okay, 40 minutes. 60 minutes. Okay.
Enjoying the discussion.
Yeah. Okay. Let's see. How can I do this one? Okay. Yeah. Okay. Let's start with the appetizer. How many of you, especially from abroad, have tried this one, bakpia? Okay. How's it taste? You like it? Okay. Yeah, we will start with the appetizer, but if you never try these ones, please buy. There are a lot of shops selling this bakpia. Yeah, okay. I will skip this one. Yeah, let me know a bit about yourself. So, especially if you're coming from abroad, where are you coming from? From Pakistan, okay. Sorry? Palestine, okay. So you? Sorry?
US.
US, okay. And other people from abroad? I know some students already. Yes? Pakistans and are you from abroad as well? Nope. Okay, it looks like Taiwan. Maybe because we have speaker from Taiwan. Okay. Yeah, I know some people also join online. So yeah, and yeah, how many of you are familiar with environmental health? Any kind of topics related to environmental health? Anything? So, or water and sanitations maybe? Nope, you're not really exposed to water and sanitations. Okay, so yeah, I hope I can give you some ideas about it, and yeah, these topics that we are going to discuss today: water and WAS, pathogen transmissions, roles on human health, and WAS surveillance. And we have some short reflections after those presentations. Yeah, and don't hesitate to ask any questions, but we will, at the end, we have a Q&A sessions, but if you want to stop me at any times, just raise your hand and we will discuss directly, okay? Otherwise, you will completely forget everything that you want to ask. And yeah, okay, I have a short question here. So among these 5 items: sanitations, hand washing, drinking water, solid waste, and liquid waste, which one has the largest effect on child malnutrition, and why? Hand washing facility, why? Source. Yeah. Other thing? Any questions? Any thoughts on this? Why? Yeah, okay. Other things? All of them? They have the same power, the same effect. Okay, we will come back to these questions after this, so you will know the situations in Indonesia, which one has the largest effect on child malnutrition. Yeah, okay, let's start with the main course. If you're coming from abroad, please try gudeg. Sorry, it's very sweet, but yeah, just try it once and never try it again. Okay. Okay, let's start with the WAS, water, sanitation, and hygiene. Okay, I always start using this picture, and this is the situations in developed countries. When I open the tap, I can drink directly from it. But B and C, they are taken from rural areas of Indonesia, and the water looks clear. Everything looks fine. The taste is okay, smell, everything is okay. But the question is, of course, you cannot drink from that. But the questions why many people in low middle income countries can have the same drinking water services as
Recording
in
in
developed
progress.
countries. What is the reasons? Why you cannot drink directly from the tap? Even in here, UGM never open the tap and drink directly from it. But what is the reason for that? Contaminations, yes, of course, that's the main reasons, because there are a lot of contaminations in Indonesia. According to the data in 2021, 7 out of 10 water source in Indonesia, they're contaminated by pathogens, by E. coli. The situation's better in 2021, but I don't really trust the data, okay? So never trust drinking water services in Indonesia. Never drink directly from it, okay? I have a lot of projects on this, but yeah, never drink directly from it. 2 weeks ago, I have a small portable water quality kits in my office, and I tested the bore well in my home, in my home, and they are contaminated by E. coli. But when I tested mineral water like this, or boiled water from the same boiled as from the well, and also from the big, usually in Indonesia we call it gallon, so big mineral water, 19 liters, and they are free from contaminations. But from my bore well, they are pathogens inside, so never drink directly from the tap. But in some areas of Indonesia, I visited quite a lot of, I travel a lot of places in Indonesia, and there are some villages, there are some projects from the NGO. They have very good water systems, water treatments, and you can drink directly from the tap. So I don't put my picture here, but usually in my class I put it there. So you open tap and just drink directly from it, okay? And they use proper and sufficient water treatment. But even in city, in Yogyakarta city, never drink directly from the tap, okay? because it's contaminated. Yeah. Okay, I want to introduce you a bit about the service ladder of WAS. So there are some levels or ladders that are introduced by the WHO and UNICEF. So for the water, there are 5 levels, and the highest level, we call it safely managed. So either safely managed water services or safely managed sanitation services. So for the water, basically it means that you have a water source that are free from contaminations. This is something that we have as in US, for example. I don't know. Yeah, US. Can you drink from the tap directly? Okay, yes. In US and in other in many developed countries. So this is the ideal situations. When you open any kind of sources, you have borewell, tap on everything. When you drink directly from it, it's safe for you. And so this is the highest ladder that we have here. But in Indonesia, the situation is more or less, I forgot to put it. It's about, I think, 20% of it they are can be categorized as safely managed. But again, I don't trust the data. Okay, so never drink directly from the tap unless I can taste chlorine. It means that, okay, it's quite safe, then I can drink from it. But if there is no taste, no smell of chlorines, never drink from the tap. Okay, and so yeah, the purpose of this, yes, of course, we want to consume and use safe water. And I just show it. Yeah, for the safely managed sanitations, it means basically that when you how do you call this? How can I say it in I don't know how to say it in yeah, okay. When you shit, okay, when you shit, when you defecate, okay. When you defecate in the toilet, your feces will yeah, go down to the systems, etc. So safely managed means that your feces, they are safely disposed and will not harm the environment. So this is the highest level of the safely managed sanitation. And in hygiene, we only have 3 ladders, 3 levels, and the highest ladder means that you have water, running water, and soap in your home. Okay, so it's very simple for hygiene, but for safely managed water and sanitations, they are more challenging compared to hygiene. So the idea of it, yes, as you said before, that if we hand wash our hand. If we do hand wash, it will prevent the pathogen transmissions, especially in the COVID situations, the number of hand washing. So the highest level of sanitation, basic ladder, they increase a lot because of the COVID situations. But there are a lot of research going on, and they said, okay, after the COVID, people start not to wash their hand regularly. Okay, so yeah. Okay, I want to introduce you a bit about the general concept of water services. I can categorize them into 2. Centralized water services and decentralized water services. So in developed countries, in here, let's say in urban area, we have the centralized water services. So we have the water source, and the water will be treated in the water treatment plant, and it will be distributed to the house. And you have tap, and you can use it directly. This is the ultimate dream of the World Health of the UN. Let's say we want to have this kind of services. So all the water, they are treated properly, and you can. That's why when you open your tap, you can drink directly from it. But in many situations, of course, in developing countries, it's not always like that. We have decentralized water services, or we call it self-supply. I have it here. Okay, I have the self-supply. So you have the point of collections of water source. We call it point of collection, means that any kind of sources where you collect your water, and then you bring it or you store it somewhere. You can boil it. You can do household water treatment, and then you have the final storage. Or if in our case here in Indonesia, in urban area, we have the big commercial water. So of course they are treated somewhere by the company, a commercial company, and then we drink directly from it. So this is the situations in many developing countries. We have the decentralized water services. And for the, okay, oh yeah, oh, wait a second, let's go back here. Okay, yeah, for the centralized water services, the responsibility more on the water supplier. So they will take care all the, everything from the water treatments, even until the distributions, the pipe distribution, etc. So the burden, let's say, the burden is on the water supplier. But if we talk about this decentralized water services, the responsibility is on household. So they, because they must make sure that that they do water treatment, or they have a clean and hygiene water storage, or if you have, like I said before, that you have the big gallon, you have to ensure that your water dispenser is clean, something like that. So the responsibility is on the household. But yeah, this is two opposite situations from these two water services. Okay, and for the sanitation services, I categorize them also into two: centralized and decentralized. So for centralized, you from your toilet, it will directly be disposed to the sewer network, and then it will be treated and reused or disposed to the environment after they are treated. But in many decentralized, in many developing countries like here in Indonesia, we have decentralized, or we call it on-site sanitation. So after you defecate, it will go to the septic tank, and then someone will bring a big truck and will empty your septic tank, and it will be transported to wastewater treatment plant, and then it will be reused or disposed to the environment. So this is the situations in many developing countries in Indonesia as well. But in some rich areas in Indonesia, they start to use this centralized system, but of course it's very expensive, and only rich people, only rich area, they can afford this kind of system. Okay, let's continue with the WAS and pathogen transfer. Okay, before I continue, is there any questions that you want to ask? Nope. Oh yes. Wastewater treatment plant. Yeah, plan. Any questions? Nope. Okay, let's start. Okay, let's continue with this WAS and pathogens transmission. Okay, I'm wondering, how many of you are never heard this term before? F diagram. Is this your first time? Okay. Really? You're my students. I teach it in the class. Okay, yes. I think that, I always teach, I always show these diagrams in my environmental health or WAS class. Okay, so yeah, the F diagram. So this shows the potential transmissions from the human, from the source feces to the future victim. So from feces, here we have the F feces. Also, all words start with F. So feces, it can transported, or it can transmit it to the future victim through several routes, fluids. So from the drinking water, if it's not treated properly, it's not clean, and finger. Okay, so your fingers can bring a lot of pathogens, and flies, of course, fields. So fields means that if you play outside, and let's say you have a pet, and they defecate in the outsides, and then you play outsides, and then somehow you touch it. So yeah, fields. And vomits, it means that the surface here, vomits and flood in this flooding, and food, and it will go to the future victim. So the sanitations is the first barrier of it. So if you have, that's why it's very important to have sanitations, safely managed sanitations, because to make sure that your vessels will not pollute the environments, and everything flies don't touch it, and everything. And the second barrier is hygiene. So but the idea is maybe there's a question. So should we just focus on sanitations and not considering the hygiene? The answer is no. So we have to do a kind of multi-barrier protection. So we have to do both. We have to ensure that we have proper sanitations and we also practice a proper hygiene. So we have to do both. Okay. Yeah. So, according to Bradley, there are 4 types of water and health diseases. So, the first one is the waterborne. This is because there's a pathogen in the drinking water, and you drink from it. So, it can cause diarrhea, hepatitis A, polio, etc. And water wash because you have a lack of water, and then you cannot practice proper hygiene, and like a skin disease, trachoma, and water based because there's a parasite in water like a Guinea worm. I have the picture here, and also water related. So Guinea worm is common in Africa. In Indonesia, there are some locations they are also they can find this kind of cases as well. So be careful when you go to the field. And the last one is the water related. Yeah, this is kind of malaria, dengue, etc. My time is yeah. Okay, I need to be faster. Okay, and if we discuss about factor influencing household drinking water quality, there are a lot of things in the house that can affect your drinking water. The first one is because of yes, of course, the water quality. So if you I did some studies and try to correlate the water quality between water source and the storage, and there are positive correlations between it. So especially if you have the same source of your drinking water. I mean, for example, you have a bore well and then you use the water from bore well for your drinking water. So there are positive correlations between it. And the next one is the recontamination from the environment or the hygiene practices. So you can see, for example, this picture. If you allow pet going inside your home, and some, of course, it can introduce contaminations, pathogens to the drinking water. You can see, for example, this is a picture. I took it from a house in rural areas. There's a dog, and next to the how do you call it in English? A bucket. Yeah, buckets contain drinking water. So of course, it's not. So the dog somehow can play nearby the buckets and can contaminate the bucket. And the next one is the recontamination from water storage. So it's important to have a clean water storage. I have a story. 2 weeks ago, we bring a water quality test to the people in northern Jogja, Sleman, Kaliurang, and then we give them a small water kit so they can test directly from their they can test directly their water storage, and they show a picture. So they do it, and then they send a picture to us, and they say that, okay, this is from my boiled water. So there's a black color, and so it means that, of course, they boil it. Boiling can kill all the pathogens, but when you have a unclean self storage, it will recontaminate your drinking water. That's why the persons show us that in his container there is a pathogen inside. And also the household water treatment here. So yeah, if you it's not common. Yeah, it's common maybe in rural areas, but in urban, as I said, we have the big they call this bottled water. Oh yeah, I want to say something. Okay, I put here a word recontaminations. It means that even though you do proper household water treatment, but if you don't have hygiene situations, it can recontaminate your drinking water. So it's important that to make sure that your storage and your surrounding environment, they are hygienic, and also they are clean to prevent the recontamination. Okay, I did some water quality model and mathematical modeling. We call it, we use the Bayesian belief network model, and we try to estimate what factors influence the water quality at home. And we found that the water quality water source critically affected the water quality at the storage, as I said before. And the next one, this is important, that the effect of household water treatment to improve the water quality is prominent in the case of better sanitation and hygiene condition. As I said before, that even though you do water treatments, but if your the kitchen situation is not hygienic, of course the effect of the household water treatment will be diminished. So it's important again to do, we call it multi-barrier protections. You treat your water, and also you have to make sure that you have a hygienic situation. Okay, and this is the pathogen transmission from the sanitation system. As I said before, that in developing countries, in Indonesia, we have the septic tank. So we have to store the feces and before someone empty it. But the problem in Indonesia that and I think in many developing countries, that we don't really have a septic or fully sealed septic tank. It means that the feces can contaminate the groundwater, and you will, for example, in my case, I have the bore well. I will extract the water from the groundwater. Of course, it will contain pathogens from the unsealed or unsealed septic tank. And these situations happens in many Indonesian house. So if you ask me, how can I know my septic tank is fully sealed or not? The answer is whether the, how do you call this in English? Septic tank company, septic tank company. How can I say it? Oh, wait a second, I forgot the Indonesia word for that. Usaha sedot tinja, bahasa Inggris apa ya? The feces emptying company. Okay, let's say the feces emptying company. You will know that your septic tank is fully sealed or not if in, let's say, in the last 5 years, the feces emptying company ever come to your house. If they never come to your house, it means that your septic tank is not fully sealed. Okay, this is the simple rules that the government use. At least 5 years. So in my case, in my home, I think 2 years ago, there's the truck comes and emptying my septic tank. But in many houses, even in urban areas, they are never emptied. So that's why it will contaminate the drinking water, the groundwater. We did some months ago. We did a study. We want to check whether there is contaminations. Whether there is a correlations between the how do you call it, the pharmaceutical ingredients in the septic tank and in the ground in the bore well. We want to check whether there is a correlations between them, and we found there's a correlations between them. So when people consume pharmacies, medicine, and if their septic tank is not fully sealed, it will we will found, let's say, how do you call this? We will find the pharmaceutical in the groundwater as well. So there is so it's not just about the pathogens, but about everything that that you consume. It will if it's not fully sealed, the septic tank, it will contaminate the groundwater. Okay. Yeah, the environmental roles in causing disease, they can cause a disease. They can be a predisposing factor, so they can increase the burden, etc. They can be the transmission media, and also they can factor influencing the disease pathway. So there's a pathway, and somehow the environment can moderate or can influence the disease pathway. And according to WHO, 24% of the global deaths are related to the environment. So it's very important that we have to take care of the environmental transmission. Okay, I cannot find the data, but I tried to make it using Claude, so I'm not sure whether this is correct or not. But if you can see that when the number of safe drinking water and sanitation increase, it will reduce the number of the communicable disease death. So yeah, this is from the low middle income countries. I tried to find it, any journal, any report on this, but I cannot find it. So yeah, but I study in Netherlands, and they always show a graph showing that when in Netherlands, they increase the water, the safely managed water services from the 70s, 80s, and it it is correlated with the number of the, I forgot, the whether the communicable disease or the diarrhea or everything. So yeah, but basically they show that in Netherlands, when you improve the quality of your drinking water, it will reduce the number of disease. So yeah, I think the situation's more or less the same in many countries, but we don't really have a proof about it. But yeah, hypothetically, we know it. This one, yeah. Okay, okay. Let's talk about the environmental anthropology. I don't know whether you are familiar with environmental anthropology or not, but many experts say that this is the main reason for malnutrition or stunting on children. Okay, environmental anthropology. So you have a human, it's a bit difficult, intestines, okay, and if you have a normal intestines, the how do you call this, the length is, how do you call this, yeah, the intestine is quite long, and the distance is so there's no distance, let's say they are closer, so it can prevent the pathogens going inside to your body. But if you have the environmental enteropathy, there is the inflammations in your intestinal, then we call it leaky. So there is a hole and the pathogens can going inside your body. And the main reason of this because of the repeated diarrhea. And of course, repeated diarrhea because of the unhygienic situations. Okay, so I wrote a small report in a small writing in the newspaper, and I said that okay, if the Indonesian government really want to reduce the number of stunting, we have a program right now called a food MBG itu apa maksudnya? Food free meal programs. And I said in the newspaper that okay, even though you have free meal programs, but if you don't improve the environmental conditions in your home, you don't have, let's say, clean, safe water, sanitation, etc., it's useless. So okay, again, because of this, even though you have a nutritious food in your home, but if the situation is not hygienic, the baby can touch everything, and they can put their mouth into their they can put their fingers into their mouth, and it can introduce the pathogen, etc. So it's just useless. So that's why it's important we can have a free nutritious meal program in Indonesia, but we have to make sure that we increase also the hygienic conditions in our home because of this. Okay, environmental enteropathy is the main reason for the stunting. Yeah, there are a lot of studies conducted in Indonesia, and they found also that poor wash conditions are related to malnutrition, and also stunting and improved water source. Again, wash is strongly correlated with the malnutrition in children. I often conducted a WASH study in East Nusa Tenggara province in Indonesia. This is one of the least developed province in Indonesia, and of course they have they don't really have a good WASH services, WASH situation in their home, and this province is I think until now is the highest prevalence of stunting in Indonesia. Okay, so there's a correlations between it. Yeah. Okay, we will come back to the first question that I asked at the beginning. Among these 5 aspects, sanitation, hand washing, drinking water, solid waste, and liquid waste, which one has the largest effect on the child malnutrition? I will use my previous study in Indonesia. So there, I will just show it. Okay, this is the overall environmental health condition in Indonesia. So we're using these 5 items, and we combine them. We combine them into one variables, and then we have this kind of map. So it shows that overall, let's say we are living in Java, in Yogyakarta. If I remember correctly, Yogyakarta has the highest score of the environmental health condition in Indonesia. So we are, let's say, in the safest province, let's say, so far. But if you move to the eastern part of Indonesia, they are not really have a good condition. I will go. Okay, so this is the results. Okay, if we so the composite score, meaning that the one variables combine that are built from these 5 variables, the composite score, they are positively associated with the nutritional status. So it means that in overall, in general, if you have better environmental health condition in your home, it will affect the it will positively affect the nutritional status. So you will have your children will be not stunted. And safely managed sanitation has the biggest influence on nutritional status. So not hand washing, they are important. Drinking water, they are important. Solid waste, liquid waste, they are important. But sanitation has the largest effect on malnutrition in children. So, and sanitation and hand washing are consistently positively associated with the nutritional status. And okay, this is important that the environmental health variables have a bigger influence compared to the socioeconomic conditions, because many people said, okay, we have to increase the economic situations of a poor household. That is true, but above all, the environmental conditions they have the bigger influence than the socioeconomic conditions. It says that even though you are poor, but if you have a good environmental health conditions, it's fine. You can have a good children. Okay, and this is the last one. Environmental health variables have a bigger influence compared to the food diversity. So we give food to the children, but at the end, as I said before, even though you give a lot of food, healthy food, nutritious food to the children, but if they don't have good environmental health conditions, it's useless. Okay. Okay, let's continue. Okay, yeah, let's talk about the water surveillance. Yeah, John Snow. This is the first epidemiologist, the first researcher that introduced the word hygiene, sanitations, and because there's a cholera outbreak in London in 1855, and the source of it is the well contaminated by sewage near septic tank. And then when this guy know that, okay, the source is because of the source of the cholera is because of the unsafe drinking water, and he damaged the what do you call it, the hand pump, and then the cases drop. Okay, so this is just a good example how WAS can prevent a lot of disease. Okay, if we talk about the drinking water surveillance, we want to have safe drinking water, but safe drinking water means that it's not only that you have water that is free from contaminations, but at the same time you have to do also a holistic risk management, because drinking water tests just analyze your water at a specific time. Maybe when you taste it now and there's no pathogens, because the pathogens they are sleeping, okay, and you will not the pathogens, but 1 minute later when you test it, you will find an pathogen inside. So it's not ensure. So zero E. coli, let's say, in your drinking water doesn't mean that your water is fully safe. So that's why we need to do a holistic risk management. We call it a water safety plan. I will show it a bit after this. So we want to make sure let's say the recontaminations from the environments doesn't occur. Okay, so the water safety plans mean this is a step-by-step risk management from the drinking water source to the to the consumer. But so it's not just the responsibility of the water supplier, as I said before, the centralized water services. The burden, the responsibility is on the water supplier. But we are, as a household, we have to take care also the situation in our home. So from the source until the water storage in our home, we have to make sure that we try to minimize the potential contaminations. Okay, the first thing that we need to do, we need to do a system assessment. We have to assess, let's say in our home, how is the conditions in our, let's say, water storage, whether there is a crack or not, whether when we look at inside there is a how do you call this, lumut bahasa Inggris apa ya? Can someone help me in Indonesian? Lumut green things inside. Okay, I I don't know how to say it in English. Where is this green plant inside? Yeah, green thing inside, or whether the inside moss. Oh yeah, moss. Yeah, whether there's a moss inside your water storage or not, it's okay. A moss because of high organic pollutant in your drinking water. So that's why you have to ensure that because organic things, this is the food source for the moss, and the moss is the food source for the pathogens. So you have to regularly check your water storage whether there is a moss inside or not. So yeah, again, the first thing you have to assess the systems, whether it's clean or not. If you have a water dispenser, whether there is a dust, let's say, surrounding or something like that, you have to check it. But the problem in Indonesia, if you have water dispenser, it's very difficult to clean it because you cannot open it. Maybe you can open it, but in my place, and I visit many houses, we cannot open the water dispenser. This is the challenge because, we never know whether there's a moss inside or dust inside or something. But okay, we have to assess the situations, and from that we try to do something to improve the situations. Okay, 3 minutes. Yeah, we have a sanitary inspections that help us to identify potential hazard or potential contaminations. There are a lot of form that can be used from the water source, pipe, water storage, even until the household level. We can use this form to help us assess the potential contaminations in our water system. Okay, for the global water surveillance, so there is a joint monitoring programs, WHO and UNICEF. They are collecting data from all countries, and they put it in the website. So you can see, if you check this website, and you will see the situation, the global situation. Even in your home country, you can check it, the status of the water services, sanitation, and hygiene services. And you will know, for example, in Indonesia, I cannot see it here, but okay, you can see the data here. So you will know how many water sources they are contaminated, etc. Okay, but the challenge for the environmental health surveillance, not just water, but environmental health surveillance in general, that there is a low political will, especially in developing countries, because our concern now, let's say, in economic development, and we are not really care about the health. Yeah, we care about health, but about the environmental health is, let's say, we don't really consider that for now. So low political will, limited fund, limited lab, insufficient equipment, remote areas, etc. So this challenge persists in many low middle income countries, including, I think, in Indonesia as well. So that's why we cannot really fully monitor the condition in Indonesia. In Indonesia, we have a big country, and in Java, it's more developed. Let's say we have a proper lab. We can do water testing. We can bring the test to the water sample to the lab. But in eastern part of Indonesia, they are remote. They are less developed. Of course, they don't have a proper equipment and lab, so you cannot really monitor the situations there. The funny thing is, there is a national drinking water surveillance in 2016. 2016, before the last one. And the funny thing that I found that the water conditions in Papua, in the eastern part of Indonesia, they have a better water quality compared to the western part of Indonesia. Okay, and we don't really, I'm not really sure about the data. So because I said, okay, maybe Java is more polluted because of the industry, etc. But I'm not really sure the eastern part, they have better water quality because they have limited equipment, they have limited lab, etc. So this challenge persists in many low middle income countries. Okay, that's why in many countries in Africa, for example, they start to introduce the portable or mobile water lab. So you have you can use motorcycle, and you can go to remote areas to test directly in their home, in their house, and you can just analyze it in the field, and you will get the results. But the challenge for this is a kind of uncertified lab. So there's a trust, because maybe people they don't trust. Okay, this is not from the governments. How can we sure that you do it properly. It happens in our case because we have a portable lab as well. I will show it here next to this. Yeah, we have a. Wait a second. Yeah, we have a portable water quality kit, but again, people, they don't trust it. Not just even people, the health agency, the district health agency, they don't trust our equipment because they said, okay, this is not certified lab. But of course, we do it according to the ISO standard. So of course, they are done properly. But yeah, this is an issue that we have to deal with in case of we don't have a proper lab. Okay, my time is finished. Okay, so yeah, if we talk about the environmental health, there are a lot of factors playing around. So we have to see the problem not just for one perspective, but we have to know that if we improve one thing, it can somehow change the situations at the end. Okay, so we have to see, for example, here, if we reduce the poverty, somehow, of course, it will positively influence the perceptions of the people. They have more money to build better toilet, to have better access to drinking water, and it will positively influence their health. And if they have a good health, somehow in the future, the children, they can have a proper job and they can raise the economic standard of the household. So we have to see the problems from a bigger perspective, that all these problems, they are interconnected. Okay, so this is a complex system. So waste systems, we often call them as a complex system, meaning that they are influencing each other, and one factors influence other, and at the end it will influence back the factors. And also there are many variables and they are interconnected. We cannot really predict the situations, and also they are context specific. So the situation in Indonesia, it will you're coming from neighboring country, for example, Malaysia or Timor-Leste, you have completely different situations. Even in Indonesia, in Yogyakarta, we have different situations compared to Central Java. So worst situations, they are context specific. So we cannot really use the same, let's say, the same policy, the same strategy across all situations. No, because we have to consider, for example, the environmental conditions, the landscape, the topography, the weather. So there are a lot of factors that we have to consider, even the social aspect. So for example, in Java, it's relatively easy to change people behavior related to waste. We can tell them, okay, you have to defecate in the toilets, blah blah blah. But in many least areas of Indonesia, least developed area of Indonesia, for example, eastern part of Indonesia, it's difficult to persuade them to change the behavior because there's a kind of cultural things. Again, that context specific is very important. So we cannot really use the same strategy across all situations. Okay, that's all from me. Yeah. Is there any questions? Oh, moderator, I give back to moderator.
It's okay, Dr. Daniel. I already told you that it's okay. The time is yours, so fully you can.
Oh, okay.
But it is okay if you have any questions. Maybe you can raise your hand or from online. Yeah, I invite. Okay, from there. Is it okay, Dr.?
From online
Sorry.
or from the audience here?
From maybe first from the audience
Okay,
here.
there are four. Okay, maybe we start from you.
Okay. Thank you, Doctor. My name is Ahmad Solihin. I have one question about portable water lab at UKM. Can you explain to us about what kind of the indicator that can be tested with this equipment? Thank you.
Can I have my slide? Yeah, in our lab we can test E. coli, we can test residual chlorine, we can test iron, nitrate. I forgot. Sorry. Iron, yes, iron. pH, of course. Turbidity, and yeah, I think that's all. Yeah.
is it commercial or you create this this portable lab?
Yeah, I credit myself for the research purpose, but we are planning to do it. We want to commercialize it. Okay, but again, the problem is because this is not a standardized lab. So that's why I said before that many people in Indonesia, they don't trust this kind of portable equipment. Kit, because they said, okay, this is not from the government lab, something. So this is the reason for that. But for the purpose of water surveillance, you just curious your water, you can do this kind of method, because it happens in many, as I said, in Africa countries, they start to using this kind of portable lab because they have limited certified lab. But the problem in Indonesia, I don't know the situation in Indonesia, we really love to have a kind of standardized something. Okay, standardized. If it's not standardized, we will not trust it. But yeah, as I said, it's difficult to have a kind of standardized. Not standardized, legalized approach for this kind of portable equipment.
Okay, thank you. And the last, if we interest with that portable water lab, can we Can we discuss in another occasion?
Yes, please. I'm happy.
Okay,
If
thank
you
you.
have any projects, this is everything that you want to do with related to WAS, feel free to contact me. I have my email, or if you cannot find my email, just type it in Google d.danielugm and you will find my contact. The funny thing, my name is Daniel, so if you type Daniel, you will never find me. Okay, so type d.danielugm and you will find me.
Okay, thank you. Yeah.
Yeah.
D.Daniel. Or maybe you can contact us if you difficult to find Daniel. Okay, thank you very much for yes.
Okay, let's start with the ladies
Yes.
first.
Okay, so first of all, thank you for the opportunity. My name is Jessica, and I want to ask, in emergency situation, whenever there's no safe drinking water, is it preferable to drink, for example, like untreated river water, or we should avoid it because the risk of waterborne diseases?
Yeah.
Because, for example, in Indonesia, we use river for bathing or washing. In that case, what the safest thing we can do? Thank you.
Okay, before I answer this, I just want to tell you that actually we have a, how do you call this? I forgot. We have another summer course next month related to the emergency something, and I will present something related to this as well. Was in the emergency setting. Okay. So in that situations, you have no choice. You have to drink, okay? But the main method that usually people do is chlorination. So they chlorinate the drinking water. So yeah, and of course it's very effective. You can drink directly from it, even though the taste and the smell maybe you don't like it, but you have no reasons. You have no option. You have to drink it, even in the situations that there is no so you have only one water source and there is no, how do you call this, eight coming, and they use the chlorinated water. If you have no options, just drink, because you need water. You may get diarrhea, but again, you have no options. You have to drink water, especially for, yeah, this is a very difficult situation, especially for the baby, because it's more risky for them. But for us, we have a kind of higher tolerance towards the unsafe drinking water.
And is it effective to use some like portable water filter?
Oh yes, depends. There are a lot of commercial portable water filter right now. You can you can buy it. For example, in my office, I have a small filter like this. So you can, like a pipette, and it has a very small pores, and I can use the pipette in the river water. So let's say if I go outside, because I often travel to remote areas and I don't trust the boiled water from and I can use the pipette directly from the river, from the water source, and it can remove all the pathogens.
Okay, thank you, Doc.
Yeah.
Okay, any other questions?
No.
Okay.
Okay, thanks for the opportunity. My name is Denny. I'm from Faculty of Biology UGM. So I have a question. In Indonesia, as we know, people must boil water or buy gallon because tap water is unsafe. In another side, sooner or later, carbon footprint from boiling water and plastic waste will pollute our water again. So, in your opinion, from one health perspective, how can environmental surveillance be used to break and fix this problem? Thank you.
Yeah, it's difficult questions. Yeah, there is a trade-off between you have easier drinking water source and also the carbon footprint. So there is a trade-off between them. So I don't know, but in my opinions, if you can have a small water filter and good water filter in your home, it's better compared to the gallon water. Okay, for example, in my parents' house, they live in Bekasi. I told them there is a commercial water filter from the Nasava. Nasava is a company from Indonesia, but they are owned by the Dutch people. So and they have I bought this water filter in my home, and my parents drink from it. So they never buy the gallon water as well. So this is one of the ways to reduce the carbon footprints. But in my home in Yogyakarta, my wife doesn't really trust the filter, so we don't buy it. But this is one of the main things that you can do: buy water filter, so you don't need to, and you can just use a tap water directly into it, and then you can drink this from it. So it's reduce a lot of costs, reduce a lot of carbon footprint. So it's good for the environment in general.
Okay.
Sorry, maybe boiling is not a good options for the environments because it's it's pollutes it costs a lot of money, and in many rural areas they use they burn the woods, so of course it create smoke in the house, so it's not really safe for the environment. So boiling, I will say that try to not using it. You can use either this kind of water filter. Yeah.
Okay. Maybe okay. One from yes. This is the last from audience, and then after that we from Zoom
sorry.
meeting.
Tadi yang di sebelah sana tanya duluan.
Oh, sorry.
Yes.
Okay. So two, yeah,
Sorry.
two. It's okay for the audience in person here.
Yes.
Okay.
Hello, doctor. My name is Faisal. I'm from anthropology. My question is, what do you think about riverside settlement, kampung pinggir sungai? We have Melayu traditions, Melayu communities living along rivers. This is commonly found in Kalimantan and also in Jakarta, Sungai Ciliwung. In this community, people often defecated directly into the river and also relate the river on dairy consumption, including water consumption. These settlements were usually located in rural areas with large and fast-flowing river. However, when people migrated to urban areas, they encounter river with very different ecological situation, but their practice at the same from the rurals. What your perspective on this phenomena? Thank you.
Yeah, there are a lot of things in your questions. So maybe the first one is, this is a challenge in many slum areas in urban areas because how do you call this, river settlement? Yeah, okay, something like that. Okay, so people live next to the river, right? So this is the problems that people live next to the river, and it's very often that they are poor. So this area as our slum area, and it's very crowded, and they have no space for the septic tank, and they will discharge directly from the toilets into the river water. So it happens a lot. That's why the government, for example, in Yogyakarta as well, they try to relocate people from this area. But of course, there are a lot of conflicts between them because they live for a long time in that area. So there are a lot of conflict. That's why, it's difficult. Or maybe, one of the strategy is they can use the centralized wastewater treatment. So all the houses, they are connected into one big septic tank, and there's a regular company will empty it. So this is one of the ways. But again, the problems, people, they don't really monitor. Yeah, they don't really monitor and take care of the system, so it's broken. It happens a lot in Yogyakarta as well. The government, they built this kind of systems near to the river, but people, they don't take care of it because the responsibility on the people. So they have to pay the fee monthly. They have to check. Someone need to check it regularly, but they don't do it, and it's broken. And again, it will the vessels will discharge directly to the river. So yeah, yes. So we have to consider these things. The potential conflict, if we relocate them, this is the best option for my opinion, because somehow you can revitalize the river, but there's a conflict, and you can use also the centralized septic tank, but people, they have to take care of it. So there are a lot of options for this, but from the anthropologist's perspective, I will say that we have to discuss first with the local community, because we don't want to propose some things that they don't like. Okay, and it's important that so I also teach an environmental health behavior, and I always say that if we come to the community, we have to give them an options. So not just one options, but we have to give them more than one option. Then they have to choose, because the decision is on them. They have kind of responsibility to practice decision that they make. So we create kind of how do you call this, sense of ownership, let's say, responsibility among them. So not tell them, okay, this is the one thing that you have to do. We offer them some options, and we have some discussion, of course, with them. I hope I answer your questions because there are a lot of things in here. Okay, yeah.
Cek. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning, everyone. My name is Muhammad Aksen Sultra. I'm from Indonesia, especially Saudi Sulawesi, and I work as a medical laboratory technology. Okay. During my 2 years in the Nusantara Sehat program, in every remote area of West Muna Regency in Saudi Sulawesi, I work with a community where open defecation in the sea was a long-standing cultural practice. Although our multidisciplinary team provided continued health education and successfully advocate for the construction of public toilet throughout the village government, many residents continue to defecate in the sea because they believe they could not defecate properly elsewhere. And according to the 2023 Indonesian Nutritional Status Survey, or SSGI, this area also had one of the highest stunting prevalence in West Muna Regency at around 38%. Okay, from the perspective of environmental surveillance and the One Health approach, how can environmental surveillance data be better integrated with nutrition and public health program to promote sustainable behavior change and reduce both environmental health risk and stunting? Thank you.
Yes, I love these questions. Okay, the problem in Indonesia is we have segregate survey for environmental health. So we have another specific survey for, let's say, WASH conditions, but we have another survey related to children health status, let's say. We have two separate surveys, so we cannot really link them. So this is the problem. So I will say that so we must have one specific survey that are, let's say, conducted by either Ministry of Health or how do you call this, BPS survey agency, the National Survey Agency. But we must have one big survey that cover all things together. So not having one separate survey for each ministry. So this is the problem. So we cannot really, this is the challenge. We cannot really link them. For example, in the SKI, Survey, basic Survey Kesehatan Indonesia, Indonesia Health Survey in 2023, we have data related to stunting and some related to WASH. But there's another survey conducted by the same ministry, so they have different parties in the ministry. They do their own survey themselves. Another survey, they have water quality data, but in the health the health survey, we don't really have water quality data, so we cannot really link the pathogen situations, the pathogen concentrations with the child malnutrition. That's the problems in Indonesia. Yeah.
Okay. Dr. Daniel, there is one in person that would like to ask questions. Who? Which one? Okay. We give a chance for these questions, and then after that we move to the online questions to make a fair between the online and on-site. Okay.
Thank you, Doctor. I understand you are specialized in WASP. 80% of PNG's population, because PNG in Indonesia, most of them, like we are middle income countries, but 80% of the population live in the remote rural areas. How does this WASP program reach the last mile? Is there any strategies, simple strategies that you can share with us? Thank you.
Yeah, it's difficult, not just in PNG, in Indonesia as well. The problem is for especially for poor rural people, they really expect to get money from the government. So we tell them to build toilets, to have also, let's say, pipe water systems, but they rely on the governments, of course, because they are poor. But from my experience, I went to many remote areas of Indonesia. Actually, people, even though rural poor people, if actually they have money to build the toilet, to build their own toilets, and to contribute somehow to the pipe water systems. Actually, they have the money, but the problem is whether we we increase their awareness or not. So this is the problems, and it takes time. It is very often that the program from the government, we really want to finish as soon as possible. Let's say we have money for 3 months and we have to build everything in 3 months, and we don't have time to really promote the people to really change their perspective. We don't really have time for this, and then so it will make that people will rely everything from the national government or for the donors, something like that. But actually, they have the money if they have changed their perception. So we have to take time to do promotions, to do health promotions to them. Let's say 6 months, let's say to them, and when they change the perceptions, there is a willingness to pay and willingness to contribute, and then they can contribute to build themselves. So the main goal is we want them to build themselves, not to rely on the outside external stakeholder. So this is the problem. So the strategy is we have to educate people, increase the awareness, create the willingness to build it, and then they can do it themselves. So we don't really give them the money. So I think this is not the best strategy right now.
Thank you. Just little bit on this the access to water, clean water. Like we know in the rural areas, there's water there. Every day people access water, like from not the treated water, but the natural flowing water. How do you think about the terms of health and this water accessibility that they have every day?
Yeah. So as I said, the ultimate goal is we want to have a water source that is free from contaminations. But if you have a kind of surface water, river, lake, for example, or lake, river, and of course, I will say that they are not fully safe. So you have to do household water treatment. So you have to treat the drinking water at your home. But as I said before, people in rural areas, they often do boiling. But there is a high chance of recontaminations if the surrounding environments and your storage is not clean. So you have to consider other aspects as well. So not just treating your water, you have to make sure that storage is clean. The surrounding environment in your kitchen, for example, they are hygienic. So they will prevent the recontamination. So we have kind of multi-barrier protections. And in rural areas, if you have a spring water, you can do also a spring protections. For example, in many rural areas, they use spring. You can protect them to prevent, let's say, animals going inside the springs and pollute it. So there are a lot of methods that you can do also in rural areas to at least prevent the contamination. So, but yeah, we have at least, but the key things is you have to treat your water at home and ensure you have hygienic conditions in your home.
Thank you, Doc.
Yeah.
Okay, we give one chance for the online participants. Maybe a brief answer is okay, bro.
Based on condition Indonesia research.
Based on condition.
Waterfall. Okay. Is it safe or not drink directly from the waterfalls? Not. Never drink from the waterfalls because you never know what happens in the upstream. For example, the waterfalls. There's a big waterfalls in Magelang. Apa sih namanya itu ya? Come on. There's a big waterfall in Magelang. So, but the problem is above the waterfall there are a big of how do you call this? A paddy field. And they use a lot of fertilizer and high amount of nitrogen, phosphorus, etc. And so never drink directly from the waterfalls. You can drink maybe directly from it if that is the last options that you have. Okay. And you check, okay, there is no agricultural area above it, so maybe you can drink from it. But I will say that never drink from the waterfalls. And in densely populated areas with poor sanitation, which sampling method is the most accurate for identifying hazardous material in mixed sanitation environment? Mixed, poor sanitation, domestic or mixed. Okay, sampling method. So far, we only have one sampling method, so you just test it directly from the sewer. So you have to, let's say you have to map first the distribution system, the sewer conditions in your city, and then you can check which point should I take sample from it, even though they are mixed by the sanitations, by the domestic waste, it's no problems because at the end, we want to, the purpose is we want to monitor the conditions in the open sewer. So we just take some points and then take water from it and we bring it to the lab and we will see the results. So there is no really specific sampling method. But if the purpose of the sampling method is we want to check directly the effect of the poor sanitations on open sewer, of course you have to take the sample close from that is close to the house, so it's not really mixed with the rainwater. I hope I answer your questions. Okay, is there any questions?
Okay, I think that's all. Your talks is very attractive and interesting. Oh, so you bring your own your own bottle. This is an example of water awareness or something like that. Yeah. And although I also curious about your wife, because in my home also use filter machine like that, and I'm still curious why your wife is still doesn't trust. But it's okay, maybe later in the backstage we can discuss. Yeah, I think this water is our concern also in Indonesia, and if you want to ask more, is it okay if we contact you or send email? Yeah, doctor. Yeah, and the next month there is also a summer course. Yeah, and Dr. Daniel will attend to that course and then give a talks, and maybe you can join. It is in Faculty of Medicine. Yeah.
Yes.
Summer course in July, right? Yeah. Okay, you can search the information of that next month summer course. Thank you very much, Dr. Daniel, for your very excellent presentations. Yeah, maybe we will give some small souvenir for you. Yeah. I hope you like it. There is no water here. Okay, a cup of tea. Yes, thank you very much. I hope in the next event you can share later. Thank you very much. Oh yeah, take a photo. Yes, thank you very much. See you. Okay, for the next speaker, maybe we can take a coffee break. Yeah, we will take a coffee break. It's okay, Prof. Chuang. Yes, and you can also take a coffee. Yeah, coffee break for 10 minutes. So we still have Yeah, 10 minutes, maybe 10:05. Yeah, 10:05. You can come back to this room. Okay. Thank you. Thank you. See you later. Okay. Thank you for um, thank you for what? Thank you for I I forget for everything. Although I already taking the coffee, but it's okay. So in this second sessions, this is the first sessions, but in the second speaker, after we talked about water, and now we talked about air. Yeah, air. In the first speaker, we talked about water, it was water, and then water contamination, etc. And now we talked about the air pollutions that will affect on our health, yeah, environment. And this is also very important for us here in Indonesia. The pollution is still the major cause of health problem. Yeah, it's like in the first sessions water, and now air. It's like avatar, avatar. Avatar. So One Health, that's why One Health is very multidisciplinary. Yeah. So from anthropologists, where is from anthropologists, biologists, yeah, medical doctor, etc. Yeah, we come and work together, yeah, to tackle or to handle the health problems around the world. Not only health, but the environmental. Now we will invite the second speaker, yeah, Prof. Chuang Xiaoqi, yeah. Prof. It's our great honor, yeah, to introduce Prof. Chuang Xiaoqi from Taipei Medical University, Taiwan, yeah. So Prof. Chuang is also my teacher, yeah, when I was studied in my PhD program in Taipei Medical University, Taiwan. So I know him, yeah. Prof. Chuang is is a distinguished researcher in environmental health whose work has significantly advance our understanding of how environmental pollutants affect human health. Maybe I will introduce briefly. Prof. Chuang is a full professor at the School of Respiratory Therapy, College of Medicine, Taipei Medical University, Taiwan. He currently serves as a president of Taiwan Society for Aerosols in Medicine and is also a visiting professor at Imperial College London, United Kingdom. And his research focuses on inhalation toxicology, aerosol therapeutics, and environmental lung diseases, and he leads the inhalation toxicology. Given his extensive expertise in environmental health and pollution-related disease, we are honored to have him with us today, and he will present pollution-related disease in environmental health risk. Prof. Chuang, the floor is yours. Take applause.
Selamat pagi. Selamat pagi. Okay, first of all, I would say thank you for having me today. I'm really honored to be here for presenting my study. And yeah, just want to mention about Dr. Daniel. I quite enjoy his talk and talking about the water because I'm also doing like a microplastic. Yeah, thank you. So from water, I'm going to talk about like air. And today I'm talking about air pollution or pollution-related disease and environmental health risk. I'm Xiaoqi Zhuang from Taipei Medical University. So the aims for talk today, I'm talking about the associations between air pollution and the COPD pathogenesis. COPD is for chronic obstructive pulmonary disease, which is very important pulmonary disease nowadays. And I'm trying to identify is there any like air pollution associated COPD phenotyping. And in the end, I'll go further to talking about like mechanisms. Is there any underlying mechanisms that are related to COPD caused by air pollution exposure? So that's 3 aims for today's talk. So first of all, I will start from like air pollution. Air pollution is very important public health issues nowadays because they will be affected about 92% of the people worldwide being kind of like suffered by different levels of air pollution. And it's not only the situation or public health concerns in like a developing country, also an important public health issues in developed countries such as the US, Europe, or Japan, and so on. So here is the pictures. We can see that a lot of like traffic emissions. This is a picture taken from like Vietnam. And the first time I visited Vietnam about like 6 years ago, it's very surprised me because there's kind of like a massive a lot of like scooters mixing with the cars. But that means the people are really living without air pollution. And the same situations, we can see that a lot of people, they use a biomass burning for cooking, as Professor Daniel just mentioned. So burning for cooking or burning for heating is very common for some countries or some areas. And if you like a barbecuing, it's still kind of like exposure to air pollution. So in fact, the situations in Indonesia, you can see the pictures in here. So the government in Indonesia, they want to put more notice and more efforts on air pollution. However, there's no people can really avoid to air pollution exposure because there's news talking about all ages are suffer and being affected by air pollution based on the data in Indonesia. And here is an island for Indonesia, and we can see there's different major sources emitted from for air pollution. The major one depends on the cities, of course, but if we're looking at deeper, we can see like the biomass burning and traffic emissions are very common emission sources between the cities. So how we can really dealing with this kind of pollutants is a very good issue nowadays, how we can really facing it and how we can prevent it. So that's a strategy that we need to know. So air quality and air pollution is very important like economic burden. So here's some countries like from India, Delhi, Mexico, and like from China, Shanghai, Japan, and Jakarta, Indonesia. You can see that about 13,000 people could be caused by premature death. And there'll be about 3.4 billions of like economic causes by the US dollars. So that means like a lot of disease that are really related to the air pollution exposure. However, how we can really understand it? So first of all, I want to talk about what is air pollution. Air pollution is including like a gas phase, solid phase, such as a dust or like a film, odor, bad smells is kind of like a definition for air pollution. And it's not only effect on humans, it's effect on animals, plants, and so on. And it's different medium, such as air pollution could also contaminate water, like Daniel just mentioned. So different contamination. And air pollution could contaminate the vegetable, the plant, that would be being taken by ourselves. So that's different rule for air pollution exposure nowadays. We should point this way. This way. Oh, okay. So the first air pollution event is being identified in 1952 in London because the industrial revolutions, people need to using burning the coal and to produce a steam. Then the machine really working. So most of these companies or manufacturers should be built nearby the river, Thames River. And during the winter conditions, the emissions or dispersions of pollutants are quite weak. So a lot of pollutant accumulated during that days. So in a week of time in London, in 1952, that caused about 4,300 deaths during a couple of days in London in the winter time. So the scientists or epidemiologists want to understand what happened. However, at that time, there's no advanced statistical approaches. So the basic way we can see by trend. So we are using like a different disease that being, kind of like increased, and we can see the trend is caused by air pollution as well. So we can see when air pollution increase, that also cause like a death by pneumonia, bronchiolitis, tuberculosis, and heart failure. So from the knowledge on that date, we can see air pollution could cause like a cardiopulmonary disease and infections as well. And about 50, 60 years after, there are lots of resources from the US or from Europe. They really want to understand what happened between air pollution and our health. So they using different types of like a cohort to build out the knowledge provided for the decision making. So this is paper published in Circulation. They identify when air pollution really increase like cardiopulmonary mortality. So we can see like chronic pulmonary disease or like cardiovascular disease and so on. This kind of disease being increases the risk by air pollution. So that gives us more confidence evidence that air pollution is really causing our health damage. But in clinics, the seasonal disease is commonly used to describe it. So when the patients come to the clinics or go to the hospital, and the doctor will say because the seasonal changes, so that's why you are admit to the hospital. However, if we're looking at deeper, we can see by different seasons, and like COPD, or like respiratory infections, tuberculosis, bronchitis being increased or being changed by the season. Of course, same as asthma. But if we're looking at the difference, we can see the COPD is significantly being changed by the season. So it's already due to the seasons and how we define the seasons and what happened by different seasons. That would be the key issues that we need to understand. So I'm talking about a little bit COPD. So COPD, chronic obstructive pulmonary disease, which is being recognized as an important public health issues nowadays. It's not only the public health issues in like a developed country and also in like a developing countries. However, it really depends on the diagnosis rate. So based on the report, it mentioned about 184 million people being suffered by the COPD, and it caused about like 3 million people death due to the COPD. And it's the third leading cause by COPD worldwide. And there are lots of risk factors. First one, we know like a smoking behavior is a major risk factor for COPD development. And then next one is like indoor-outdoor air pollution. And the third one is occupational dust exposure. So that means the smoking, air pollution from indoor-outdoor, and the occupational exposure are the major causes that leading to the COPD development. However, if we identifying the COPD by different experimental design, so there'll be two different designs, such as like if we do like a retrospective study. So that means we collect the COPD patients, and we see how the historical smoking behavior, and we can identify the association about 80% of like a COPD patient, they had the smoking history. So remember, 80% from the patient. But if we do like a prospective study, that means we collect a healthy subject and following a period of time, which calls like a cohort study, then that will be about 40 to 50% of the smokers now will develop to COPD. So we can see the difference by its different experiment design. If we collect a patient to see the smoking history, that'll be 80%. But if we collect the healthy subject and do a long-term follow-up, that'll be only 40% to 50%. So that'll be around the 30% difference. So what happened and what's the difference? So based on the Lancet report, they mentioned about globally, about 55% of COPD subjects, they don't have the smoking history. So that means beyond the smoking, there would be the other factors that really affected on our lung. So what's the factors? First one is the air pollution from indoor-outdoor. Normally, we burning biomasses for the cooking. That will be the major exposure, probably from the indoor. And the traffic emissions that we post probably from like outdoor air pollution, or there's some industries emissions that causing our outdoor air pollution as well. And the other one factor is asthma. Then there'll be occupational exposure, such as like minings or like weldings, this kind of disease that caused by occupational exposure. And then like infections or like the other types of like lung development due to pregnancies and so on, like different factors. Of course, aging is a major factor for COPD. So based on the GOLD guideline, which is the standard guideline for diagnosis COPD, they try to identify is there any etiologies for COPD. So they distinguish and classify it by COPD-G, G is for gene, and such as like alpha-1 antitrypsin deficiency. And the other one is COPD-D. So it's due to abnormal development, such as like when a woman during the pregnancy, they still do the smoking, or they still do some like walking, but however, exposed to high levels of like dust or air pollution, or they are exposed to relative higher air pollution level already. So kind of like affect their like baby development and leading to like immature or premature lung development during the pregnancy period. And the other one is we call it COPD-C. So it's very interesting. From the GOLD guideline, they try to distinguish the difference between like smoking and the air pollution, because the scientists realized that there could be some difference. Of course, the exposure are different, but the phenotyping or the etiologies could be different by the smoking behavior for COPD-C and the COPD-P. P is for like pollutions. So if like COPD not really related to air pollution or like biomass burning, so we can call it ET top for like COPD-P. And the other one is COPD-I. So it's for like infections. Then COPD-A, it's kind of overlapping between asthma and COPD. A portion of asthma patients, they will develop into COPD in the end. So it's kind of like overlapping. And the other one is the unknown factor. There's still small portions of COPD that's still unknown. So the first evidence that being identified by epidemiologists due to air pollution is like a lung function decline in the lung. So this is a study that identified the air pollution exposure such as like PM 2.5. PM stands for particulate matter, 2.5 is for the particle size fractions. So 2.5 means like a 2.5 micrometer in air diameter. So if we say it's a PM10, which means like a 10 micrometer in air diameter. So PM 2.5 and nitrous dioxide are the major sources. And nitrous dioxide is for like traffic emissions. So we can see that the subject who is exposed to air pollution could lead into like lung function decline by FVC decrease and like FVC delta decrease and so on. But if we're looking at the degree of a decrease, we can identify that like healthy subjects, they are more vulnerable to air pollution exposure by lung function decline when compared with the COPD. But as our knowledge, we think about the COPD could be more sensitive to air pollution. But what happened? Because COPD is irreversible lung disease. So that means when the lung function declined, the lung function cannot really be reserved or reversed by the medical treatment. However, for the healthy subject, the lung function still can be reserved. So they have more like a degree that can be changed. So in terms of like a COPD, there are two types that are commonly being identified. One is bronchiolitis, the other one is emphysema. Bronchiolitis means like after continuous stimulations by like oxidative stress or like by the inflammation, the airway wall will be getting thickness, and that will be increasing or reducing the lung functions. And the other one is emphysema. Emphysema means like alveolar, the wall, just like a honeycomb, but it's kind of being destroyed. So that means the more air being held into a lung, distal lung, but the air cannot really be exhaled. So it's kind of leading to air trapping in the lung in COPD patients. So what types of like phenotypings of a COPD, bronchiolitis or emphysema is really related to air pollution or both of them? That raises a question to the scientist. So first of all, in our group, we start a cohort study and we try to understanding occupational dust exposure, which means like a mental field exposure. Is that really can leading to like a COPD development or causing like a lung function decline? So based on like epidemiology decide, and if we can select a occupational cohort, that will be much easier for us by like to get evidence from the general cohort study, because for the occupation cohort, it's more clear for the cost and the outcome. So it's easier to identify the causal relationship, because this kind of subject, they are mainly exposed to certain type of risk under the working environment. So in our work, we have done about 10 years follow-up from the shipyard worker in Taiwan, and now we collect data for 4 years to see how about like a COPD development from a healthy worker to like a COPD. And surprisingly, we can identify around the 2.5 overall incidence rate in the workers, and the workers are mainly exposed like a welding film. But based on the OSA, they're talking about a welding film is kind of like a fever-like symptom, not only causing like a short-term breathlessness or like leading to the short-term uncomfortable like illness and so on. So based on occupational definitions, they don't think the welding film exposure is really an important occupational health concern. But based on the study, we identify after long-term exposure to like welding film, that will be leading to the COPD development. And especially we can see the non-smoker have higher incidence rate when compared with like a non-smoker. That's very interesting. So supposedly non-smokers, they probably have like a more lung function that can be really declined by like a welding film, because smokers, there has been kind of like lung function being destroyed by smoking behaviors already. And of course, the welders, they have higher risk by incidence rate when compared with the office worker. And interesting in this one, the personal protective mask is like a welding mask. It's already help to protect workers' health, especially in the lung respiratory system. So based on results, if the worker wears, doesn't matter they wear the mask or not, we still can see the incidence rate are quite equally. So what happened? Because during the welding, it's really hot, humid. So properly welding the mask is very important. So it's more like a behavior science or like social science, how we can teach, educate workers and to make sure they're wearing the mask properly. That's a key issue. It's not only for like occupational health, it's also for their personal health as well. But in the end, we can see after occupational exposure, the lung function of dust declined by welding exposure. So that gives us an evidence that air pollution is really associated with like a COPD development. And as I just mentioned, bronchiolitis or emphysema, which type is really associated with like air pollution. And this is a report published by JAMA. They use two type of experiment design. It's very interesting. And now they're more and more like a good ranked journal. They use two experiment design to get evidence. So first of all is a cross-sectional experiment design, which means at the point when the subject being recruited into our study. So it's a baseline. So based on baseline, they can do the retrospective air pollution exposure by different years based on the residential addresses. So based on the study, they identify different types of air pollution, including a gas pollutant, ozone, or particulate matter, PM2.5. They are also associated with like emphysema risk. But when this cohort being followed up for 10 years, we can see the risk for the emphysema progression only can be identified in the gas pollutants only. So is that real? How about the particulate matters? Because particulate matters has been recognized as an important public health issues in terms of like air pollution exposure as well. So we try to confirm the report, the evidences from the JAMA study. So we conduct a meta-analysis study, and based on study, not surprised, we still can see the gas pollutants such as ozone is really associated with the emphysema. So that's the things. Gas pollutants is associated with like COPD, and it may be associated with emphysema development. And in fact, for the animal model, if you want to induce emphysema animal model, put the mice exposed to ozone is one of the model to induce emphysema. So that makes sense. But how about particulate matter? So we try to identify what happened. Is there any like subgroupings, mistake, and can we get a really precisely associations that between air pollution, particulate matters, and emphysema? So we collect around hundreds of subjects in hospital and collect like the CT scan, and based on CT scan, they can identify which type of emphysema that really belong to in COPD subject. And we use different types of emphysema, such as like parastole or centrolobular or like paralobular, different kind of like emphysema type, and try to associate it with particle matter. And based on the particle matter exposure, we using the particle deposition model because different patients, they have a different lung function that will be affect the particle deposition after inhalations. So we personalizes the deposition rate by the air pollutions, so we can do further association between air pollutions with like a different emphysema lobe. So we still can see the association between gas pollutant. However, we can identify most of like a risk with a higher risk being can be identified in like a lower in lower lobe emphysema. So let us raising a questions, because we have identified associations in the subject. But for me, I'm doing like inhalation toxicology. So animal to prove the concept is much more important because we get the associations from epidemiology. Of course, we can get association by cohort study. We can identify the cultural relationship. However, if we can using the animal, it's much easier to looking at your X and the Y. Y means like an outcome. So we build out a real world exposure system. Why we use this system? Because traditionally, if we want to look at inhalation toxicology, we prepare the particle suspended in like PBS, and we use a microspray do the intratracheal isolation into the mice directly. It's a standard approach is to do like pharmacology testing or toxicology testing. However, this kind of approaches cannot really use for long-term exposure because asthma and COPD are this kind of like chronic pulmonary disease. So if we're using the intratracheal isolation, that'll be induce like a man-made damages by ourselves. So we try to figure out is there any approaches that we can use. So we are building a real-world exposure system, and we introduce the unconcentrated, just ambient air into our system. And at the beginning, we use a particle classifier, so we remove most of like a larger particle. So only PM2.5 can really introduce to our system. And there are two groups. One is with the HEPA filter. So that means we remove most of particle matter. So in that group, only gas pollutants are exposed to the mice. And then last group is, we call it PM2.5 groups. That means the mice is exposed to like particle matters and gas pollutant at the same time, compared with the control, the mice housed in like animal center. So this is the picture for the entire system. And at the same time, we measure the air pollution levels and to see how the pollution exposure during like 3 months or 6 months of time. And we look at the system in Taipei City, in the National Taiwan University campus, and nearby is a Keelung Road. So here is very busy street. So we can see a lot of traffic during like a peak hour or like a rush hour. At the same time, there's an air quality monitor station operated by the EPA station, operated by the EPA. So that means the mice is really exposed to traffic emission sources. So the mice expose the air we breathe. So what happened after like 3 months of time, 6 months of time? So we conduct about 3 months period of time. Actually, we originally planned to do 6 months exposure. However, after 3 months exposure, COVID happened. So we have to terminate the study. So we get a result for 3 months only. And during the 3 months, there will be 3 periods of dust storm. It's mainly come from China. So we can do the source of measurement to understanding where's the long range transport from. And we can see it's from like different cities of China. Some pass by Korea, some are not. But the receptors is Taipei. So the mice is exposed to like a long range transport air pollution as well. And at the same time, we collect the particle matter on the filter subject. And we use a filter subject to do different types of like chemical analysis, such as like metals and polyaromatic hydrocarbon, so which means called like PAHs, which has identified as a first-class carcinogen. So we can see the daily variations over different types like metals and different types of pHs that enable us to understanding what the mice really exposed and what's the major chemical compound that could be causing like damage in the lung of mice. And we also do exposure, we also do like lung deposition model. As I just mentioned, we use that for estimated particle deposition in COPD subjects as well. So after 3 months exposure, we can see most of particles are deposited in alveolar region, and the other portions are trachea and bronchial regions. So that means more than half of particles are able to deposit into like alveolar region, the distal lung, and to interact with alveolar epithelial cells. So let's move to the animal results. We can see that after 3 months exposure, the lung function did decline by air pollution, especially by the particulate matters. And the lung function decline is associated with the metals that the animal really exposed. We can see like magnesium and cuprous are really associated with the lung function decline in the mice. And the next one is try to reduce, because the 3R, reduce, reuse, refinement for the animal welfare. So we measured the lung structures by HRCT. So we can using HRCT to reconstruct the lung, and then we use a reconstruct lung imaging to measure the emphysema by different period of time. So the red color means like the emphysema occurred by different groups, and then this is reconstructions. We can see more and more like emphysema development in the distal lung of like the mice, and also being confirmed by histology observation. So emphysema means like the alveolar wall really being destroyed. So this is normal animal, the normal alveolar structure, and after PM 2.5 exposure, we can see that the structure has been destroyed. And we also see the air wall thickness being increased by air pollution exposure. So based on the results between the CT scan and histology observations, we can really understanding air pollution really did the emphysema development. And the next one is very surprisingly. So we want to do the confirmations on patients. So we collect the lung tissue from COPD subject who exposed to higher air pollution area during one period of time. And in the picture here, we can see there's a lot of black color-like particle really deposit on, we call it AT2 cell, type 2 alveolar epithelial cells in here, in COPD subjects. So that means the particle really being trapped in COPD lung, and which can be really be observed by the lung imaging, and which means like there are more and more particles really being kind of like being trapped in COPD subject. So let's move back to the animal. So we try to understanding what happened on the alveolar wall. So we using the surface marker. SPC is for the type 2 alveolar epithelial cell, and the T1 alpha is the surface marker for the type 1 alveolar epithelial cell. So after exposure, we can see significant decreases for the AT2 cells and AT1 cells by air pollution exposure. And then we using the RNA sequencing and the single cell RNA sequencing to see how's the effect and what's the potential mechanisms underlies by air pollutions on AT2 cells. So we observe it be associated like the oxidative stress, inflammations, and mitochondrial functions. These kind of things are very general. However, we found the Hippo pathway will be really involved into like a lung AT2 cells in response to air pollutions. So what is the AT2 cell and what is the Hippo pathway? So AT2 cell, which I just mentioned, is a type 2 alveolar epithelial cell, which is a progenitor cell. So in the alveolar wall, the AT2 cells, which is a very important one cells that can differentiate into AT1 to maintain the structures of like alveoli, and also it can proliferate to the new AT2 cells. So these kind of cells being if like a dysfunction, that means like no cells can really differentiate into AT1, so leading to like alveolar wall being destruction. And the Hippo pathway means like let two Hippo pathway signaling component, one's the YAP, one's the TAS, they need to be translocated into the nucleus to activate the function of the AT2 cell. Then the AT2 cell can really differentiate from the AT2 to AT1. So that means if the function being dysfunctioned, that means like the AT2 cells cannot really differentiate into AT1 cells. So based on results, we using a serial model to see how the air pollution is really associated with like a regulation in AT2 in Hippo pathway by YAS and TAS, and we can see that expression is dynamic, which depends on the exposure period of time by different hours. We can see it's really being changed by particulate matters in 24 hours, and the results is also being confirmed in animals. So we collect lung sections from the animal to see how the AT2, AT1 cells and how the expression by the YAP signaling pathway. So we can see the YAP is still being decreases by the PM2.5, which means like it's really destroyed the function, dysfunctioned the Hippo pathway, and leading to the YAP or TAS cannot really translocate into a nucleus and inactivate the function of AT2 differentiate into AT1. And after the dysfunction, then the cell will processing or programmed to cell death by ATN, P53, and P21 pathway. So this is the summary pictures that being done by Vincent, one of my students. And we found air pollution exposure is really associated with emphysema and that dysfunction like AT2 cells by regulating the Hippo pathway. So that'll be the final slide. So in conclusions, I would like to say air pollution is a very important public health issues. It's not only associated with asthma, but it's also associated with COPD. And why I'm doing COPD? Because asthma is treatable. So the patients can really be managed by medications. However, for COPD, it's untreatable. So for the clinicians, they only can manage the COPD patient, not get acute suspicion, because frequent acute suspicion that leading to a lung function decline. So that decreases the quality of life in COPD subject and also probably leading to like a patient death in the end because the lung function declined. And the air pollution is not only important issues, and it also being important in the non-smokers. So when clinicians, they try to understanding how the risk factors that are really leading to like a disease progress or disease development. First things is try to asking the basic or like we call it patient history. So how's your like behavior looks like? Are you smoking, and are you cooking at home, and are you do like incense burning? Of course, there's not many people do the incense burning, and how the pollutants you really exposed to. These kind of factors really help us, the clinicians, to do the diagnosis, and we can provide more information to teach the patient how you can protect yourself. And the other one is in biological views, we can identify alveolar epithelial injury caused by like a Hippo pathway are very important, which could be also associated with like emphysema development. And in the end, there's urgent need for like a cleaner air policy, exposure reduction, and the early intervention strategy try to mitigate like a growing respiratory health burden. So there are three things we need to do in terms of like a public health student. Because for my background, I graduated from like occupational health and safety in public health school. So I would say public health is very important because it's preventive disease happened. So we need more effort to let like a public to understanding how we can protect ourselves. So the public awareness are very important, and we need more like efforts to pursue and push the government to do So, and the other one is exposure reduction. Is more like environmental engineering. So how we can reduce it, and it also associated with public health or the other expertise, because you can either teach or you can let your friends know that by banning this kind of behavior, smoking are not good for you. So try to do this kind of behavior changes and reduce the air pollution exposure. For example, if there is a wildfire or building fires, were you close to see the fires or not? Normally, people will. So we'll go closer to see the fires. However, if you have awareness, you will note if you're close to the fires, you probably exposed to higher pollutants. Of course, it depends on the wind directions. So you are in the like a downwind or like a upwind, it's different levels of exposure. And then the other one is early intervention strategies. So how we can do early intervention strategies by clinics. So either if a patient come in, we can give them more evidence or more like educations, how you can prevent yourself. It's not for the medication, not for the diagnosis. It's reduce the risk of severities in patients in the future. So that's on my side. I would like to say thank you, Dr. Farah and Dr. Vincent as well. And thanks all my research group and the funding resource. And thank everyone. I'm happy to be here.
Thank you, Prof. Chuang, for your very interesting talks and very excellent. And this is the big concern of all of us, in the world, and especially in Indonesia, regarding the air pollutions. Okay, we open for discussions. If there are, and okay, one, and then second, three, okay.
Good afternoon, Professor. My name is Hamza Abu Layel, PhD student, UKM, Department of Physiology. Thank you for interesting topic and interesting presentation. Just I want to say something about the COPD. We know this is a progressive disease and irreversible damage for the lung, and sometimes we need to find solution before we reach the COPD, because there are some disease we can treat with it, but when we say COPD, I think the damage, it will be irreversible. So when we talking about the air pollution, we talk about a direct a relationship with the number of the people. For example, in Indonesia, there are more than 200 million people live here, and sometimes you cannot change the air pollution. So sometimes we need to find the solution. The solution like we using or wearing mask. Is it this is the one of the solution, or in my previous research says that exercise play important role to prevent COPD and many disease, because we know when you try to start in the exercise regularly, this means more efficient in the inhalation and exhalation. So I want your advice, which the best way to protect us from the air pollution, because sometimes you cannot change the pollution in Indonesia or in another region. Thank you so much, Prof.
Yes, very good questions, to be honest. So how we can protect ourselves? Of course, wearing a mask is one strategy. But I would like to say it's for yourself. So how we can change everyone. So I think that will be much more important. So I've been to Indonesia several times, and thanks for Dr. Farah's invitation. And every time if we go to certain areas, we can see it's open firing, burning like a trash or rubbish. And it seems like they think this is kind of like a biomass because they're doing cooking at the same time. For me, it's really surprised to me. But the two levels of things. So how we can improve or we can change their behavior, I think it's really difficult. It's really being limited by like your family income, of course. So the first thing is try to let everyone understanding exposure to air pollution is really important, and it's not only associated with like a respiratory system, it's also associated like a disease. Because based on our study, we identify air pollution exposure is also associated with like a neurodegenerative disease as well, such as like neurosensitive like a CNS toxicity or Parkinson's and so on, and it also associated like a memory deficiency. So first things I would like to say is protect yourself and try to change the behavior from your family first. That's the first things that we can do. And for being a teacher, I'm talking about the air pollution, how important it is, and how we can change ourselves. So I would like to say for the young generations, it's still on time, not today. You still can do that, change by yourself, and you can change the behavior for your college. At the same time, I think if everyone do something, that'll be improved a lot. That's the first things. And then second is the exercise. Now that's very interesting because in Taiwan, we often take a walk about 7 to 8 o'clock. I know it's very late, but the people really want to do some exercise. So the rest time we can do exercise is at night. So we don't normally do exercise around like 8 or 9 o'clock because it's very hot in Taiwan, Taipei. However, for the scientific view, because Taipei is an urban area, so a lot of traffic emission sources. So for me, I try to avoid any pollutions being emitted into the atmosphere. So if you do like exercise at night, at around 9 to 10 o'clock, it's fine because the PM 2.5 level is decreased. However, the gas pollutants is increased. So it's really difficult. You cannot really choose which time will be better for doing the exercise. So I choose the other option. I work out in the gym. So that's the option. And the other one is, I would like to say is, when I do the exercise outdoor, are you doing like a nose breathing or mouth breathing? Yeah, it's different. If we do a mouth breathing, that increase about 20% of particle really being inhaled into a lung. Because our extrapulmonary system, the nasal and health system, is really important to remove the particle. About 60% of the particle can really be removed, especially for large particle, by our nasal system because anatomy. Yeah, so most of large particle can be removed. However, if we do like exercise juggling, use the mouth, that means most of particle, I mean the large one, are being held into our lung directly. So that causing more dangers to our lung system. It's a very important things that we need to notice. So I would like to say is when you do the exercises, of course, you can choose indoor. There are lots of indoor exercise you can do. Or you want to do the outdoor exercise, you probably need to choose better time and a good environment. And I would not recommend to wear the mask for juggling because you probably will causing like hypoxia in the end. Okay, thank you.
Okay, thank you. The second, yeah.
Thank you very much. Good morning, everyone. Thank you, Professor, for coming up with such fresh perspectives on pollution-related diseases. And I really appreciate how you reframed the challenges around this topic. But my question is not about this topic, since so far I know this is the last day for the series of lectures. Tomorrow we are going for a field visit, so I think I may not get the chance to ask this question. My question is about the effectiveness of One Health approach. I'm from Bangladesh. I'm talking from Bangladesh perspective. So far I understand public health, especially One Health, the three components, human, animal, and environment, belongs to three separate departments. Human health belongs to health department. Animal belongs to livestock and environment belongs to forestry and environment in Bangladesh. So my question is, to what extent do you believe in a low-income country like Bangladesh, public health, One Health approach is effective, where bureaucratic hurdle is almost impossible to overcome? Thank you very much.
Yeah, it's a very good question, to be honest. So I would say it's a different discipline have a different expertise. And One Health is a very wide spectrum. Actually, it's cover almost everything. Now, medicines, biology, engineering, environmental sciences, and social science. It's almost everything. So different discipline have different aspect and different approaches to dealing with the public health issues. But I would like to tell me for example, my background, as I just mentioned, is public health, and then I did my PhD in inhalation toxicology and focusing on lung repairing, pathophysiology and repairing. So I jumped a little bit from like a data analysis to toxicology, and in the end now I'm working in the medical school. So I would like to say is the first thing is probably you need to think about how you can expand yourself. So not just focus on the expertise that you are really studying. So because now the AI is coming, everything is changing too fast, to be honest. And before the COVID, I don't think AI is very important to me. That would be really affected my job because I have no concern about the AI before the COVID. But after the COVID, it seems like everything been changed, right? Too fast, to be honest. And even me, I done epidemiology work and do the traditional statistical analysis. But nowadays, I show the images about lung imaging reconstruction, and the analysis done by AI. So that means I really involved in the AI already. So what I'm going to say is One Health is try to unite everyone together and try to solve out the health issues. And for the one, I think the one is for, I would like to say for the narrow view, probably the one means like entire countries, because different countries have different problems. So how we can unite together and try to get more resources or like public awarenesses to dealing with the issues that we are really facing to. That's the first things. In Taiwan, we are really facing to different issues. Of course, air pollution and water shortage. There are lots of things we are facing too. But Indonesia, I think probably Dr. Farah have more idea than me because I just do short-term visit. But as far as I know, I would like to say as in developing countries, I know not enough resources, what we can do. That's really the main things. And I would say is you probably can do something, try to let people understanding or become the teachers in the future. You can let your student really understanding how important it is. And but I would say in these stages is get the knowledge that you have and try to do like a public awareness to everyone, and of course do something.
Thank you.
Okay, thank you.
Hi, my name is Mudassir Asim. I'm from Pakistan, a PhD student in MECOM University, Jogja. So my question is that during your recapitulations, you passed like a remarks on that asthma is treatable or bypass. So how do you support your comment on it? Though asthma is one of the, I guess, is serious health issues. So how do you explain or support your idea or your comment on it? Thank you.
Yeah, that's a good point. So I would say is why I do the COPD, and asthma is important, right? Can I say so? Is that the question you ask?
Yeah. How do you support your comment?
Yeah. So I would like to say that originally because asthma and COPD are the common chronic pulmonary disease throughout the world. And there's still a lot of medications that try to identifying and try to treating the patient for asthma. And why I choose the COPD, that's the first thing I would like to say, because first of all, it's untreatable. So for me, I want to, from the public health of view, try to identify the risk. So for me, identify the risk. So it's much more important for epidemiological evidence we identify, so we can see children, elderly, existing disease patients, their population risk in terms of air pollution in COPD. So I would say is identify risk is important. And the next one is we get association, how we prove our hypothesis or prove a concept. So we're using different approaches. So for my student, first of all, is we try to make the hypothesis based on the meta-analysis. So we try to understanding, is that work being done already? So is this really work that we can do by meta-analysis that give us more evidence? Is that real or unreal? Is that something that haven't done already? So we use a meta-analysis to generate hypothesis. Then we go back to the epidemiology again for the data analysis to prove the hypothesis that we rest in our mind. Then we find some associations already based on data analysis. So next one is by using animal first. Actually, some people using cell first, but we're using animal because animal results are more relevant to the human because of different barriers of a system we use to prove a concept. So we're using the animal build out different type of disease model. So today's talk I mentioned about is the one example for the disease model that we have. And we're also using different type of genetic knockout mice to prove the different genes that will be associated with the disease. So using a model to prove concept, then using a serial model to prove a molecular pathway. So it's a strategy that we are using. And I would like to say more and how we can really translate the results we identify from the population and risk. Intermittent is an animal and to the medicine. So we identify certain type of biomarkers in COPD who is highly associated with air pollution. So we collect these kind of the proteins, analyze it by proteomics, and then we confirm it in patient again, and then go back to animal to prove a concept. So we identify the ITH4 protein, which cooperate with Dr. Farah as well. So we're using the ITH4 knockout mice. So we house the mice for almost an year to see is that spontaneous development, COPD, by emphysema in the knockout mice. And interesting, we found the gene knockout is really associated with COPD emphysema development. And we do one more air pollution charge to see if that really increase the severity or leading to acute suspicion or not. So it's all the model we build out. So we found the ITH4 is important. Then how we can do treating. So now we are doing the drug development. So we build out a ITH4 molecular drug, and for me now we are doing the drug formulation because for the lung inhalations, by inhalations is much more important than IV injections or taking the pill. So we developed ITH4 inhaled powder drug, and then now it's finished the preclinical study, and we are almost going to the phase 1 study already. So Hamilton's is public health is important. And if we can go further to connect with medicines, then we probably can get more, and we can probably treating the patients in the future. Thank you.
Okay, thank you, Prof, for your answer. Okay, Jessica, yes, maybe. Is there any?
I have question.
Oh, sorry. Oh yeah, you can first. But yes, yeah, you can raise question. It's okay.
Good morning, Professor. So thank you so much for such a insightful session. So my name is Mohammad Arif, and I'm from Pakistan also, and I'm a student of public policy and government. So my question is more about the societal issue that I have saw when I am in Indonesia. When a bad habit becomes a culture,
So what do you suggest about it? Because in Indonesia, every person, not all, but most of them smoking, right? And this is a really big issue. And I have done a project on that the government also increases the price of the smoke cigarettes, but then because of the so porous borders, so a lot of smuggling smoke cigarettes also come inside the Indonesia. That's the same issue also. So what do you suggest about that? That when a bad habit becomes a culture, so how to get rid of it? Is there any safe smoking solution or some filtering or something like that? Because it's very hard. And even though if you ban it, people even smoke in a smuggling way. Yeah. Thank you so much.
Yeah. Indeed, I noticed that smoking is really big issues in certain countries, such like Indonesia. So it's smoking a lot, and the same as China. I was in China last year, and I was trying to check in the hotel, and there's one guy who's smoking in the lobby. Really surprised to me, just indoor smoking nearby me. So how we really facing the smoking? I would like to say is, of course, if you can quit, if the people can really quit the smoke, that would be much important. However, I don't think it's easy to do so. So I will not say any policies that we can do. Of course, we need to change the mind and probably using different kind of approaches to reduce the smoking. So I will take Taiwan for example. The government wants to control the smoking behaviors. So first thing is reduce the secondhand smoke. For me, I'm not a smoker. I'm really annoying by the smokers because it's smelling very bad. So first of all, I'll try to avoid the secondhand smoke. So the government using the restricted area. So this area is only for the smoker. So you want to smoke, only there can smoke, and otherwise you'll get fined. And there's no smoking at home, even in the backyard. Okay, so there's some people think I'm at home, it's my house, so I can smoke everywhere. So if you really smoke at home, you are not really affected yourself only, also affect your family and your children. So think about everything about your family. I think that'll be very important. So there are few things that we can organize this. I'm not sure, but I noticed that in the airport, of course, probably in the airport, there's areas for smoking, but for the public areas, it seems like smoking everywhere. So I know it's still a long way to go, but probably we can have like certain area that the smoker can really smoke. But for a non-smoker, can really avoid the secondhand smoke. So that's the first thing I would say for the non-smoker. And then for the smokers, we are doing the cigarette smoke study now, and to compare with the heat tobacco product. And we are not doing the e-cigarette because it's too dangerous, and we are not sure what has been the major component inside. So different components have different health effect. But now we do the comparison between the traditional cigarette smoke and the heat tobacco product. We found that different burning approaches could really have different health impact. But I would like to say it's a good behavior. I would like to say is try to quit the smoke. Yeah.
Okay. Is it?
Can I comment on it? The government is giving awareness on to stop like smoking. Smoking is injurious to health. They are giving advertisement each and everything. But on the same time, the government is providing the smoking area. Why? I mean, like, don't you think it's
government also seller of the cigarettes?
Yeah,
is one of the biggest
that's
seller.
wrong because in Taiwan, everyone talking about human rights, right? What's your right? So the government cannot really prohibit to ban the smoking, right? So let the smoker have an area that can really smoke. So that's their freedom. But for the non-smoker, we have our right as well. So we don't want to expose to secondhand smoke. So the government want to do some separation. The areas is for the smoking only, but most of the areas are free smoke. So that's the first things. And I know you say it's kind of controversial, but in Taiwan, there's some policy that using. One is put a lot of like lung cancer's picture on the box of a cigarette smoke and on a cigarette. and banded advertised on like a TV or anything, and they increasing the price. Yeah, the price is very higher in Taiwan for smoking.
Yeah, even let's suppose I'm smoking. So if I take one cigarette, it's like nothing. But let's suppose if I go to the smoking area, it's already covered in smoke, and it will directly affect more than one cigarette.
The consequences of smokers. Okay, maybe we give one chance to the in-person participants, and after they move to the Zoom participants.
Okay, first of all, thank you for the opportunity, Prof. My name is Jessica, and I'm from Yogyakarta, Indonesia. I want to ask, from a One Health perspective, which intervention should be prioritized first to reduce COPD in non-smokers, like improving air quality, or strengthening tobacco control, or like reducing occupational exposure? Thank you.
Okay, so in terms of like One Health, I would like to say is like environment is much more important because yes, they are talking about climate change. So air pollution is also being affected by temperature, humidity under climate change. But climate change will be the other issues. I'm not talking about it today. But in terms of like One Health perspective, how we really change it or to improve our abilities, I would like to say is adoption. So how we really adapt the environment, like the Professor Daniel, he mentioned about we can use a filtration and so on. But I think it's for our self-protections. So how we really adapt that different steps. So from like public health, of course, we can like teaching the people for educations, and we can prevent the disease happen. But for the biology, for like pharmacology and so on, we'll try to understanding what's the mechanisms, identify any drug or pathways that are really involved in the disease development. And for the medicines, of course, treating patient, and probably the patient will facing more challenged by the disease severity under the air pollution exposure or under climate change, because based on our report, we found the air pollution increase treatment time. That means a patient being acute suspicion in hospital, they need more time to be discharged and the difficult treating by infections as well. So that's different aspect. But for One Health, I would like to say is it's try to increase our adoption and awareness and be prepared.
Okay, thank you.
Thank you.
Okay, thank you. We now moving to from Zoom, from Joseph Dargantes from Philippines. Yeah, thank you, Professor, for the very informative lecture. Is there a global regulatory body that oversees and monitors air pollution worldwide, particularly with respect to compliance with 2021 WHO Global Air Quality Guidelines? Yes. Say hi to, for in Philippines.
Yeah, and I think it's very good questions. And then after the WHO, they set up a new guideline, and the guideline I would like to say is too low in terms of like PM 2.5 or different types of air pollutants levels. Even Europe or US cannot really reach to the guideline. So based on like epidemiological evidence, they say that if lower like a 5 microgram per cubic meters for PM 2.5 in a day's exposure. However, the 5 micrograms, you can think about it. It's very hard to imagine how low it would be. Like I would like to say for this environment, probably around the 10-ish microgram per cubic meters, and outdoor probably even higher. So now more and more like a medical society, they try to pursue the WHO to reduce or to change their air quality guideline step by step, not to the end directly. We need to more realistic. If we do like something that really can down to 5 microgram in Indonesia, generally outdoor will be 40 to 50 microgram. So you need to 10 times harder to reduce it. But it's for general. It's not really including like traffic emissions and so on, or like indoor air pollution. So even in Taiwan, the average will be 15 to 20. So it's really difficult So I would like to say is if we want to look at the WHO guideline, the medical society try to change the policy, and we need to do that step by step. Thank you.
Okay, thank you, because unfortunately the time is limited. So give applause to Professor. Yes, this is very interesting questions. Also, recently, if we talked about exercising outside, outdoor, the marathon, yeah, Prof, it's become more popular. So I also wondering how about this when there are so many people a marathon, yeah, in the regularly, and then they export from air pollution. It's also my concerns. And then you also mentioned about the public awareness, and then our in education for wearing mask. Yeah, wearing mask in Indonesia also need more effort to educate. Also my my concerns also. Okay, thank you very much. If you want to ask, yeah, to discuss about the air pollutions, and then want to more get information from Prof Chuang, you can send an email to Prof Chuang. And if want to get a contact, maybe you can also ask the committee of summer course. Thank you very much once again. And there is one, yes, a little souvenir. Yes. Thank you for sharing. Yes. Thank you. Oh, this is also Professor Chuang students. That's the papers already shown by Professor Chuang. Yeah, Dr. Vincent. Yeah, you can find him in radiology, travel radiology. And for the third speaker, Bapak Dr. Anis. Yeah, unfortunately he cannot come here because there is some any invitation, yeah, from Minister of Health, so he cannot come in person, and he will send the video, yeah. Then so that's why maybe there is no QA sessions, but you can ask him by mail or maybe in Elo. Yeah, in Elo there is a discussion form, yeah, and you can ask there. Okay, maybe this is Pak Anis. Pak Anis is a researcher and lecturer in population health informatics, and more than 15 years of experience in research and consultancy in collaboration with the Ministry of Health, BPJS, Kesehatan, hospitals, district health offices, and private sectors. And now he working in council, member of the Asia eHealth Information Network, head of the Data and Information Division of the Indonesian Hospital Associations, and co-principal investigator of LPDV-funded regulatory and box for e-malaria project. Okay, maybe we can start to play a movie. Okay.
Assalamualaikum warahmatullahi wabarakatuh. Good morning. First of all, I apologize could not joining the summer course in place due to other activities. So before starting the session, I would like to introduce myself. My name is Anis from the Department of Biostatistics, Epidemiology, and Population Health. The committee invited me to share the idea related to the integration of human, animal, and environment data. If you have any questions after this session, feel free to contact by email. So we start with this slide. We have a patient on the left side, a poultry farm in the middle, and also a river. Seems like these three are not connected one to another. But if we mention about antibiotic for the patient in the hospital or the use of antibiotic in the poultry farm, then we can have a connection between three if there is also residual of antibiotic entering the wastewater system in the river. So this is actually the story behind this integration of environment, animal, and human data related to One Health. The figure here illustrates what happens in the real world. Antimicrobial resistance does not move along a single pathways. It moves through hospital, uh, through farms, and also through wastewater or environment. And it is actually as part of the biggest situation when we call a silent pandemic, because according to the study in Lancet, it mentioned about the huge number of casualties attributed to antimicrobial resistance. Even though they already identified several leading IMR pathogens, the question right now is what will be the action of us as human to counter the potential upcoming pandemic. As we know, for example, the current situation, these casualties due to IMR is even higher compared to other famous disease like HIV or malaria. With regard to preparing for this silent pandemic, the question right now is how we use the existing data from the hospital, farm, and also river, so that we can use this data not only as a part of each problem in this sector, but also as the whole situation, understanding about the antimicrobial resistance. But this is actually the blind spot of human endeavor to counter the AMR. It is a blind spot where the data disconnected one to another, and data is still in the silos located in the different system using different standard. This picture actually give us a better understanding why integrating health data is also among the One Health big challenges. When we come into detail, and then we could see that even, for example, on how to collect the data, there will be issues about, for example, the standard, the workflow of data, and also how to identify from one sector to another. This slide could also be useful for us to understand about the importance of environment as the location where resistance evolve and spreads, and connecting between human and also animal sector. So that's why I think this is also among the important reasons for the summer course to discuss about integrating data is important in One Health because pathogens don't respect boundaries, and we need also to have this data in the human health, environmental health, and also animal health to be connected one to another. When they are connected one to another, for the case of antimicrobial resistance, we could also understand about the dynamics, about the traveling, the moving, the spreading, and also the persistence of the antibiotic in environment, and also the impact to the human. So based on this slide, we expect that having integrated data could improve us to have a better intelligence, and then having a faster actions to have a better, healthier. Uh, this is actually among the biggest challenge in One Health, especially because of what we mentioned, we still have or we still facing the data silos in each sector, which is not connected to one to another. And this data silos is important for us to monitor the situation in each sector. But if we talk about One Health, it is not only the situation in each sector. It should be connected one to another. And if it is connected one to another, as we move along our journey on the technologies, we expect that all data, when already connected, we can use several technologies, including approach, to understand better, to improve our surveillance system, and then to use several method using machine learning or big data, so that we could have also the mechanism or action to predict the situation, and giving early warning to our communities. So, like what we discussed in the previous slide, we expect that integrating health data could improve our action on One Health program by providing early warning, hotspot detection, where the location of any outbreak is happening, the prediction trend, and also the pandemic preparedness. So the question right now is, can we move from the isolated surveillance system toward One Health integration and then One Health intelligence? The next slide of our presentation was actually taken from a previous project. We work together with several partners, including the Ministry of Health, FINE, and IHIN, to study about One Health IMR surveillance and using the HL7 Fire Playbook for Indonesia Satu Sehat program. This slide was actually taken from the Indonesian of at the time, I was the principal investigator for this research, involving several researchers from different institutions. At the time, our study was actually trying to develop standard data and interoperability for One Health IMR surveillance. Because of it is also quite complex problem, we start with stakeholder mappings, identifying all stakeholders in the human sectors, animal environment, and conducting landscape analysis to review all the document, regulations, policy documents, and also visiting health facilities in terms of the AMR surveillance practices, and to conduct a gap analysis related to the IMR surveillance data and system, and then develop a data standard for interoperability, and finally recommending the interoperability for a Satu Sehat platform at the Ministry of Health. In terms of the landscape analysis, like what we mentioned before, we conduct a document review, site visit, and also in-depth interview with several stakeholders, and also doing a mapping of data system. Like what we discussed before, in the real time in Indonesia, We know that in human health, a hospital is collecting IMR data through sentinel and routine surveillance that was developed by certain stakeholders, including our committee for antimicrobial resistance. In the animal sector, there was also information system called ISIGNAS and IV Lab to collect data related to the IMR. And also on the environment, there was also surveillance using wastewater surveillance, but it is not a routinely used, no dedicated system, and it is still based on the sampling survey on certain location. This is just a big picture that the data are still silos between these three sectors in One Health. Based on our analysis, we identified several stakeholders related to the antimicrobial resistance and antimicrobial use in Indonesia. And we AMR, it is still limited to only 20 hospital in 2021 and becoming 74 in 2023. As you know, in Indonesia, we have about 3,100 hospitals. And the implementation of One Health IMR, when we call IMR, it is still fragmented. As in Indonesia or the Ministry of Health implemented Satu Sehat and National SIZA system, Sistem Informasi Zoonosis, it is also not well integrated. ISIGNAS already covers antimicrobial use, but it is not yet fully integrated with IMR surveillance. And the implementation of Rencana Aksi Nasional of IMR still faces several challenges. This is part of the landscape analysis. We also identify that Indonesia is also quite dynamic on the policy implementation of IMR. And among the challenges, but also I think opportunities, there are several stakeholders involved in the IMR surveillance. And when we call about One Health, I think it is also related to several ministries as well. And especially in the current presidential cabinet with the new number of ministries, I think this structures is not valid anymore. But I think in terms of the dynamic of the structures and stakeholder collaboration, it is very important for us if we would like to integrate animal, environment, and also human data to understand about the current stakeholders mapping. We also identify from each sector the surveillance system of each. We identify the data source, we identify the software, and we also identify to whom the data collected and disseminated. From each sectors, we identify, for example, in hospital, what data that they collected, in Puskesmas, in the national reference laboratories, and also from the pharmaceutical services. This is in the human health that looks like all data already coordinated in terms of the stakeholders, the data source, also reporting mechanisms into the national as well as in the global level. We also identify the surveillance system in the animal and environment. But as we mentioned before, the environment sector, we have challenges in terms of the routinity of the data. For animal health, they have also routine data collected. We also identify software for using for conducting this kind of surveillance. For example, on IMR, we identified IV Lab for antimicrobial use. There is also ISIGNAS. and also the responsible ministries who is managing this kind of regulations, and also to whom the data will or should be submitted to the national level and until to the global level. So based on our understanding, we identify that Indonesia has a strong uh, foundational framework in terms of the policy at the national level. But we need more integrated cross-sectoral approach to implement One Health. In terms of the data, we saw that data is still fragmented, diverse digitalization capacities. It is different from human health, animal, and also environmental health. We also observe the inconsistent data standard, the issue of manual data entry also among the burden by users. We also identified limited real-time reporting, and I think in terms of the reporting system in the human health sector is quite mature compared to other sectors, even though there is still needs something to be improved. And also we identify also opportunities for improving the capacity of human resources. During our project, we identify that there was also a gap between sectors. We need to implement One Health approach. I think this concept of implementing One Health approach is also useful for other sectors, and we also propose on how to improve the knowledge and capacity of the human resources. And the last one related to the data, we also identify that there are opportunities and good opportunities in health sector as a model on how to developing the standard data that could also be useful for integrating One Health data. So I move forward into these topics on leveraging Satu Sehat and interoperability standard for antimicrobial resistance and use surveillance. This is the story about this setting. Even though we mentioned that in the health sector, the maturity level is better compared to other sector, but we still observe this situation. In hospital, laboratory staff enter result of lab exams into laboratory information system, and then retype summaries into Excel, and then we have also ONET, and then and later recompile data into web-based reporting to the national level or the Ministry of Health. In primary care, doctors already record antibiotic use on IMR system, but they are still asked to manually fill separate indicators related to the use of rational antibiotic use for respiratory infection and diarrhea. The result of this information being typed again and again, one patient, many entries, it is a sample of inefficient, frustrating, and also potentially risking the quality of services to the patient. So after we conduct this desk review, observing the situation in the health facilities, we identify that there is also opportunities for the health sector to improve our antimicrobial resistance surveillance using standard data, in which the Ministry of Health already adopted several standards, like, for example, the standard for disease classification using ICD-10, a standard for laboratory terminology of Loing, standard for medical nomenclature using Nosonomicity, standard of classification drug of KFA, and also the standard for data exchange using FHIR HL7. It is already there, but then unfortunately it is not well or not adopted into the IMR surveillance. So we expect that if the Ministry of Health consistent to use this kind of standard, we could also improve the health facilities that previously using many system, entering different system to just use one data that could also be used to many system. That is what we propose and what we expected. In the context of the health system, for those who do not familiar with the Satu Sehat, Satu Sehat is the national platform for the health data exchange in the health sector. It is a standard that started to be developed during the COVID-19. At the time, we have the application Peduli Lindungi, but then using this HL7 FHIR, it is already developed and disseminated by the Ministry of Health to be by all vendors, so that all vendors, when they develop EMR, electronic medical record, it is expected that they follow the standard from the Ministry of Health. So this standard is expected to ensure interoperability from one system to another, but the implementation is somehow is still limited. When we mention HL7 FHIR, the analogy is like Bahasa Indonesia or Indonesian language. As you know, in Indonesia, we have many tribes. I think there are more than 700 languages and dialect, but we have Indonesian language in which every tribes could speak one to another. It is also like when we talk in English, people from Indonesia, Japan, Malaysia could also use English as part of the uh, communication method between one to another. So HL7 FHIR is also like a standard that allow every system to speak the same language and then sending data from one to another. In HL7 FHIR, Fast Healthcare Interoperability Resources, they also identify several terminologies like the standard of Loing, City, etc. So, for example, when there is a prescription of ceftriaxone or result of E. coli resistance, there is also standard in City regarding this E. coli resistance, and also the standard of Kamus Farmasi Alat Kesehatan or drug code that is standardized so that it can be followed by one to another. This is just an example of resources from HL7 FHIR that they mention that there are several resources, including, for example, the resources in terms of the terminology, like what we mentioned before, including also standard for security, and also resources, for example, in terms of the lab result or the observation. So this kind of standard is already there. But right now is how about to implement and to ensure all health facilities to implement this kind of standard. To implement this, Ministry of Health developed a playbook. Playbook is such kind of a guideline in which this guideline should be adopted or should be followed. For example, in Satu Sehat platform, they develop the playbook or interoperability system on tuberculosis should follow this Satu Sehat playbook. But we do not have the playbook for antimicrobial resistance. In the Satu Sehat playbook for tuberculosis, it mentioned the detailed standard regarding, for example, the patient registration, anamnesis, physical exam, the classification of TB cases, etc., etc., etc. So when we visited several hospitals during our observation on IMR surveillance, we saw that every hospital still maintaining their own standard. It is not comply to the FHIR HL7. And also the Ministry of Health do not yet develop this playbook for IMR surveillance. So like what we mentioned before, this playbook of tuberculosis, it mentioned, for example, in terms of the coding system, what coding system that should be followed. For example, in terms of the type of laboratory result, they should follow Loing, Sonomet-City, etc., etc. And this is also among the result of our previous study. We propose to adopt the WHO guideline for IMR-MU surveillance in Indonesia. And this paper actually mentioning about our proposed playbook for antimicrobial resistance and antimicrobial use. In this book, we propose about the standard of variables, including, for example, all resources and also all element data that should be provided by every electronic medical record providers and also health facilities that use EMR. So we mentioned about, for example, if there is a request for sample testing, this samples testing is part of the HL7 FHIR resources on specimen, and there was also a coding of this kind of specimen, either blood, urine, or other type of specimen. In the playbook, we also develop this kind of workflow on how to implement IMR surveillance following this Satu Sehat playbook framework. And we also propose how the data connected started from for example, in several hospitals, they use devices for antimicrobial testing, and then these devices should be connected to the laboratory information system. Laboratory information system should be connected to the EMR, so the staff in the hospital do not entry gain from one system to another. And then it should be connected to the Satu Sehat interoperability layer at the Ministry of Health. And finally, it could also be connected to the dashboard and could also be sent to the national level. So this is what we expect if this scenario is happening. In case there is a case in the hospital when a doctor requests for blood culture test. So in the EMR system, they select this type of specimen, it's blood, and behind the system, it is already comply to this kind of HL7 FHIR standard. So this HL7 FHIR standard, we have this data, it's already standardized. And then if the result is already produced, for example, after the microbiological testing, the result is E. coli. So, I'm sorry. So the test result could also be provided and then comply to the standard. And if the standard is available, the standard will then be submitted to the Satu Sehat. In the Satu Sehat platform, if they comply to the standard, it is also good as well if the global antimicrobial resistance surveillance level from the WHO also comply to this standard. So if they comply to this standard, the burden of data entry will not be happen anymore. This is the nice thing of having this kind of standard. So this is what we propose from our studies after conducting landscape analysis and then observing health facilities. identify the gap, and then what we propose is developing this playbook. And after conducting this study, we already identify the current situation in human, animal, and also environment. And we see that in terms of the standard and terminology, I think the human is quite mature compared to other. We have also this kind of data exchange protocol, and also we have also smallest aggregation level data in terms of the individual, not in the population like in animal. But yes, I think this is also among the concern before we are starting to discuss about integrating data from human health, animal, and also environmental data. So I think we are getting close into our presentation. So after we discuss about this IMR surveillance, we see that this is IMR is a major global health problem, and integrating data is one of the, I think, important endeavor to challenge with these data silos. But to challenge with data silos, we also understood the different maturity level of data system and information system among these three sectors. But then, yes, we agree that forward-looking, it is important to have this kind of interoperability among these three sectors. And in the health sector, it is a good example that we adopted this kind of standard. But by then, I think we need to have this kind of approach on how to integrate between the human health sector, the animal, and environment. Whether the integration will be on the dashboard level or should be down into for example, into the district level, or should be specifically as part of the data for evidence base or action. I think this kind of idea is very important, and also hopefully potential for those who would like to continue the study about integrating data from these three sectors. In the previous slide, we also mentioned about not only integration, but also becoming intelligence. I think this is also among the objective or the vision, which we need to continue, not just stop on the collecting data, not just stop on integrating data, but how to use this kind of data. As we move forward for many interesting opportunities for innovating using, for example, big data, AI, etc. I think we need to start first with the foundation. We need to improve the data quality, the completeness, and the timeliness for surveillance data, including in the human, animal, and also environment, and also enhance the surveillance system across the sector. And at the same time, I think we need also to work forward on reducing the fragmentation and also data silos. Our program on enabling the interoperability and integration is also part of the endeavor to have this kind of harmonized and interoperable One Health data across sectors. But among the challenges of our project is that we have already produced this playbook, but it is not yet implemented. It is not yet trained. So I think the next part is we hope that sectors or stakeholders interested to adopt this playbook for training or even implement it, and also given the opportunities of AI and several new technologies, I think for those who already improving the data quality, it is also good to start and thinking about adopting this kind of new technologies, like AI, for example. So we hope that if we work parallelly, the data quality initiative and also AI and also others, we can move from uh, data collection until integrating and also having intelligence based on our One Health data, and then having a better actions to counter the antimicrobial resistance. And I think the last recommendation from our presentation is that even though our story is mostly about the antimicrobial resistance, the context of integrating data in One Health is also applicable to other contexts. For example, zoonotic diseases, emerging infectious disease, wastewater, food safety, and also the pandemic preparedness and response. I think that's my sharing. I'm very sorry that I could not join you in the summer course. But if you have any question, feel free to contact me. And thank you very much for your participation and listening. Thank you. Wassalamualaikum warahmatullahi wabarakatuh.
And then if you want to send your questions, you can in Elo, yeah, like I mentioned before, or you can send him email. I think that's very interesting topic, yeah, in integration, yeah, Satu Sehat, yeah, and then we need to integrate our data. Okay, after this we have lunch before our last sessions. But before that, I would like to share small informations about our study program. So this is like a small promotions. So we also have a master study program in public health in Minat concentration One Health, yeah. One Health, we have One Health concentration in public health study program for master, but we also have tropical medicine, yeah, tropical medicine for study program. If you are interested, you can apply for this semester, last semester. The deadline is 30 June 30th. Yes, yeah, we share this. So this is for Indonesian, also for international student. Yeah, it's yes. Itu ya, ini berdua. And if you are from Adinkes ya, ada yang di sini mungkin dari rumah sakit atau dari puskesmas ya, misalnya ini kita mendapat potongan ya, potongan dari Adinkes ya. Kalau misalnya teman-teman ada rekomendasi Adinkes juga bisa apply dengan SPP yang akan lebih murah. Bisa buat teman-teman, bisa juga di-share ke temannya. You can share to your friends ya, to your friends. This is for international and local student, it's fine. Thank you. Huh? Understand bahasa? Wow, yeah, you already here 1 month, 4 months, but you can speak bahasa. Maybe you can share your friends, yeah. Yeah. Yeah, so yes, yeah. So in Faculty of Medicine, Public Health and Nursing, we have many study program, master program for One Health. Yeah, One Health in study program master. One Health Master in Public Health, and this is Tropical Medicine. For Master in Tropical Medicine, we have 3 concentration for infectious disease, and then laboratory, and then also entomology. Yeah, please share and If you want to follow our social media, you can get any information from that related to infectious disease and tropical medicine, etc. Thank you very much. See you, and you can go for lunch and then praying, etc. And then we can back here in 1 p.m. for another 2 speakers. Okay, thank you. Bye-bye.
All right, welcome back everyone. I hope you had an enjoyable lunch break. And for those who joining us online, I hope you already take your lunch break too. So now we will move on to the next next session. And in this afternoon session will be our last session with our distinguished speakers here with us from Chulalongkorn University, Thailand, and from Universitas Gadjah Mada. Now, let me introduce our sixth moderator that will lead this session, Dr. Yudi Ratna Nugrahani, Master of Science, Doctor of Philosophy. A brief introduction about Dr. Yudi. She is a lecturer at Department of Parasitology, Faculty of Veterinary Medicine, Universitas Gadjah Mada. She is also a secretary of Veterinary Professional Education Study Program. And from 2026 until 2025, she is head of Quality Assurance Faculty of Veterinary Medicine and also an editor of Journal Science Veterinaire and International Journal of Veterinary Science. In 2012 until 2016, she is a veterinarian in Animal Health Center, Dinas Peternakan, Kabupaten Kulon Progo. So please join me in welcome Dr. Yudi.
Okay, thank you. Hello everyone, good afternoon. So how are you today? It's good, right? Feeling sleepy? Because it's time to sleep. Okay, on behalf of Universitas Gadjah Mada, I would like to honor to welcoming you all in this summer course. Transdisciplinary One Health approach to emerging and emerging disease. And our focus this afternoon is on the critical thing, environmental and integrated surveillance system, and from surveillance to action, policy and preparedness. Okay, and it is my great privilege also to introduce our distinguished speaker, Prof. Morakot Keutamasorn from Faculty of Veterinary Science, Chulalongkorn University. So he is a full professor right now from Chulalongkorn University and also director of the Center of Excellence in Veterinary Parasitology. And also he expert in the veterinary parasitology, vector-borne disease, focusing in zoonotic pathogen in livestock and also in wildlife. So, and he is with us now. So please welcome Prof. Morakot. So his work has been instrumental in strengthening the role of veterinary science, and he is a vet. As also he focused on emerging infectious disease. So today Prof. Morakot will share his insight on how environmental surveillance system can be integrated into public health, and also how surveillance data can be translated into effective policy and also action. And this topic is particularly relevant to we continue to face the global challenge in zoonotic disease and also pandemic prevention. Okay, so thank you very much, Prof. Morakot. So the floor is yours. Please.
Okay, thank you very much, Yudi. And I'm very honored to be part of this summer course. So today my topic will be about zoonotic risk and animal health facility as a first gatekeeper. So when we talk about zoonotic risk, you need to think about likelihood of disease that could spread between. Oh, I can see it, right? Okay. Zoonotic is from animal and human, but actually you need to think about environment as well, right? People, animal, and environment. Environment is very broad term, right? There will be a lot of factors that involved with this zoonotic risk. For example, deforestation. You might familiar when the tourism is growing. Sometimes you need to move to the forest, building a resort, something like that, and that make people close to wildlife animal, for example. Or sometimes you need to have expand agriculture or some other tourism. For example, you go to the forest for trekking, for the cave exploration, something like that. This is the chance that the zoonotic risk will happen. So when we talk about zoonotic diseases, the cause of the disease are very broad. Many of you may familiar with viruses, or sometimes it can caused by bacteria and parasite or even fungi. But of course, you may know from my introduction that I am most familiar with parasite because I'm in this field for many years, for a long time. So there are several modes of transmission that might cause spillover from animal to human. First thing that you may know is direct contact, right? Direct contact means you get close to the source of the pathogen. For example, if you are with a pet animal, you might be at risk of, for example, rabies. That's why in many countries they have recommendation for the animal to have rabies vaccination, for example. And sometimes it can happen from when you play with the animal. For example, in this case, it's cat scratch disease. Do you know what kind of pathogen that causes the disease? I already wrote it here. It's virus, bacteria, or parasite, or fungus. Which one? No, this is not parasite. This is bacteria, right? Are you familiar with this name? Bartonella. It's attack blood cells actually. But the source are from cat. Of course, this bacteria is not only transmit entirely by direct contact. Sometimes it's you have also vector. In this case, it's a flea. Do you know flea? It's kind of arthropod that live in the cat, right? Okay. So another route of transmission, which is vector-borne disease. When you talk about vector, the most important vector that kill people the most, do you know which one? Arthropod. I already showed it. Number one is mosquito, right? Number one is mosquito. Number two is tick. Of course, there might be some other blood-sucking insect, for example, sandfly or something else, flea or many other. So in this case, for example, mosquito-borne disease can cause, for example, like in this region, there could be, for example, malaria. If it parasite, if it virus, it could be dengue virus or some other pathogen. The second important vector-borne disease is tick-borne disease. But actually, tick-borne disease in my field, which is veterinary field, tick-borne is number one. But in medical field, number one is mosquito. Please remind me how many minutes left, for example. I afraid I will. So the other route of transmission is foodborne disease, food and waterborne disease, because you have to eat every day, right? You cannot stop eating, right? So there is a high chance that you increase eat some contaminated food. For example, in this case, I show you one kind of parasite that the larva stage you can find in the pig meat. Did you see white color here? In many countries, they eat this kind of food not well cooked actually. Sometimes they may cook, but only this side and this side, for example, quickly undercooked food. And then what happened to them is like this: the parasite get into the body, to the brain, to the eye, something like this. And it's endemic in Southeast Asia also. Maybe you are lucky, you may eat, you may don't eat pig or pork, right? Okay, next. This is you will find this kind of parasite in the raw pig. So the other mode of transmission is environment. So sometimes you need to be at least at some environment. In this case, it's the example is hantavirus. You might read some new recently, right? There is a incident of hantavirus infection that happened. So animal health facility can serve as the first line of the defense against zoonotic disease. We can stop the pathogen from jumping from animal to human. Actually, it's not jumping. Actually, the word may not misleading, right? The parasite cannot jump directly to your mouth, for example. Maybe not. So in many cases, it jump by helping of, for example, vector. Like I said, it's a topic that I'm most familiar with. There are many kinds of vector, right? So what we need to do is we know the source and we manage things accordingly, something like that. So you need to know it first. You can manage it properly. Okay. The frontline role of animal health facility will be, for example, animal clinic, veterinarian, farmer, and people who work in the lab, because they can identify the source of pathogen first, so they can be the first gatekeeper. If they open the gate, the pathogen can move somewhere else, for example. So we should focus on three factors. For example, the first one is surveillance and early detection. Surveillance, meaning you need to look for them, because approximately 70% of new infectious disease that happen right now is originate from animal, right? So if you can find them easily or early detection, you can manage the rest process. For example, preventive care. You can manage about biosecurity or the other preventive measure later properly. So because I'm veterinarian, so I will show you why the veterinarian are a key to prevent the next pandemic, right? This is because the veterinarian, we need to work closely with animal. That is a source of spillover from animal to human. Actually, when you talk about animal, there are many kinds of animal. You may most familiar with a pet animal, right? But there are many other animals, for example, a livestock animal or even wildlife animal. You may think you are living in the city and you may not at least of wildlife pathogen, but actually, if you walk in the campus at night, if you notice, you may find bats fly over your head, but most of the people don't realize, I guess, because I guess like this, because when I start my career, I didn't do research with bat, for example. I thought the bat is a bird, for example. I don't know it. But in fact, it's close to your life than you may think. And the other animal that might be very good reservoir for many pathogens also, for example, monkey, long-tail macaque. Because I give you example, share my experience from Thailand, because in Thailand, monkey has a conflict with people because nobody eat monkey, right? They have no predator, so they can overpopulate and invade into your house. It happened in many provinces in Thailand. You may surprise, it's including Bangkok. In some area, there is a problem of monkey with people, especially the area near the coastline. They have like a forest, and the monkey live there, for example. Okay. So I will give you, share with you my experience. I will focus on surveillance and early detection because I work a lot on this field. When you do surveillance and early detection, there are several methods that you can use, either by direct or indirect method. Direct method means you find the pathogen directly. You may find, for example, the parasite, the virus, the bacteria directly. Indirect method meaning some pathogen, when they infect to animal or people, human, they disappear quickly. Do you understand, right? When you try to find them, you won't find them. For example, what you have to do is you are looking for their maybe fingerprint, for example, but actually they don't have fingerprint. But in this case, they have, for example, you look for antibody from hosts that respond to their infection, for example, because the virus or parasite or bacteria already gone, for example. You cannot find them directly. Okay, so there are so many methods that you might use. First one is conventional method. Do you understand conventional method, right? Conventional method is the method that everyone use conventionally. For example, I work with, for example, I try to find people who have malaria, for example. Conventional method is you take small amount of blood and then put on the slide and make thin bar smear and stain with some color and then look under microscope. We call microscopic examination. And if you find the pathogen, this is this pathogen, for example, right? This is conventional. Another method is advanced. Sometimes conventional method may not enough, for example. You cannot find some pathogen. Can you conclude that there is no that pathogen? If you cannot find, what you have to report is not found. That's it. You cannot report that there is no this pathogen. You just cannot find it. You understand what I mean? So advanced method may help in this aspect. For example, you may use nucleic acid amplification method. You look for DNA, RNA of the pathogen, or you look for protein of the pathogen, something like that. So if you do surveillance and early detection properly, the benefit will be you will have proper preventive care and biosecurity, mean to prevent the next outbreak. So I give you the example of direct and indirect method. For example, this is the left hand is the direct method. You find pathogen in the blood. This is what kind of pathogen are you familiar with? Can you tell me what is it? This is what kind of pathogen? No. This is not. It's a protozoa. I have one hint. It's a protozoa. Protozoa means single cell organism, right? Animal. Actually, it's animal. So this is a trypanosome. Trypanosome. And it's okay for you because normally it's sometimes the prevalence is not high actually, but it may high in in South America, for example. But in this area we also have some zoonotic disease that caused by this kind of parasite. There are many species of this parasite. This is direct method. And another, this is indirect. You may familiar with. You use rapid test a lot, right? And you look for antibody response. But I guess many of you are medical students. So between the two methods, none of them are perfect. You know, right? Between direct and indirect, none of them are perfectly good maybe in your situation because each method have its own limitation, right? For example, sometimes direct method investigation, sometimes the pathogen disappear quickly, for example. You may not find, or some pathogen may be in the blood circulation for a short period of time, and then they are hiding in some internal organ, for example. Can you give me the example? What pathogen that behave like that, for example? What pathogen is, when you collect blood sample, is not a good sample that you want to test? First, you need to know first what kind of sample is good for what pathogen, right? You need to know behavior of the pathogen or biology of the pathogen first, for example. I will answer you in the next slide. Okay. So this is comparison between conventional and advanced method. Conventional, of course, its advantage is quick and cheap. For example, you do a blood examination, you can do it on site. For example, you just have to have a microscope, right? You can look quickly, especially, for example, trypanosome. You drop the blood on the glass slide and cover with cover slip, and then look the movement, for example. What kind of pathogen apart from trypanosome that you can find like that? Find the movement. Another one may be Filaria, for example. Right? Are you familiar with Filaria? Filariasis or elephantitis. Are you familiar? This is a mosquito-borne disease, right? But the problem of conventional method is the sensitivity sometimes is low sensitivity, meaning if you have a little number of the pathogen in your blood circulation, you might not find them, for example, right? But you cannot tell the patient that you are safe, you don't have this, maybe not like that, but because the method you are using is not sensitive enough, for example, right? That's why we have some advanced tool. You may look for the pathogen by looking at maybe RNA, DNA. What is the advantage of looking for DNA or RNA of the pathogen? Can you tell me the advantage that is we can improve sensitivity when compared with conventional method? The keyword is amplifiable. Amplifiable. Yeah. For RNA, DNA, if the original sample you have only one copy, you try to look, you may not find, right? But for molecular method, you can amplify them from 1 to like this. Yeah, PCR, RT-PCR, whatever, or like this. This example is another variant of PCR we call LAMP. It's a PCR using the thermostable temperature. You don't need to use PCR machine. You just incubate the sample at certain temperature and the color change, we find, it's positive, something like that, right? There are many methods that you can use. How many minutes left, sorry? 17. Oh, the time is there. Okay. Okay, I want to move back to conventional method a little bit because in this slide I show you sometimes pathogen that you are working with, they look identical. The morphology itself is indistinguishable, but actually they are different pathogens. Can you follow what I'm trying to say? When you try to identify pathogen, sometimes they look the same face, but they are different kind of pathogen. This is another limit of conventional method. You cannot say this is pathogen A or B because they look the same. So in our region, we have one pathogen called malaria, zoonotic malaria, Plasmodium knowlesi. Before the PCR method was invented, we totally rely on microscopic examination, and at that time we thought this is only Plasmodium falciparum only. You understand what I mean? But many years later, after PCR method was invented, people from Malaysia, they go back to the glass slide, blood slide that made long time ago, and then they scratch the blood on the slide, extract the DNA and amplify it and confirm it. It's not falciparum. It's knowlesi, for example. Actually, it's not the fault of people who diagnosed at that time because the technique is limited, right? Something like this. This is the reason why you cannot differentiate. This is knowlesi, this is falciparum. They share some similarity, very high similarity. That's why misdiagnosis can happen. Okay. So what I try to emphasize is pathogen that involving animal and environment and human have different characteristics, different behavior, right? That's why when you choose surveillance method, you need to use it properly with some kind of knowledge or background about that kind of pathogen that you are working with. Okay. From this photo, can you tell me what is the probable disease? Can you give me the differential diagnosis, for example, the possibility of what kind of disease based on based on information. This is zoonosis actually. Have you ever seen a lesion like this? Something like this? This lesion also can happen with people. Can you guess? Okay, it's okay. Next is you do some examination and you find this. For example, now can you tell me? No, it's okay. Because I know you are not the parasitologist. I not blame you. It's okay. But actually, if you are a medical student, this is zoonosis. So this is another kind of parasite, vector-borne parasite, transmitted by sandfly. Are you familiar with sandfly? Sandfly, are you familiar with? I'm not surprised if you know mosquito, but sandfly, do you know?
Even smaller than mosquito.
Four times smaller than mosquito. That's why not so many people are aware of this transmission. So this is leishmania. Actually, it's closely related to trypanosome. Actually, something like this. So, actually, it happened in Thailand like this. This is vector. You may not familiar with. But the photo itself may not represent its real size, because in reality it's very small. You may not see it actually. But when it bites, it's very painful actually. Okay. This is a lesion that you find in animal. So we detect it. Someone make a rapid test and it's positive. It's positive. At that time I try to collect blood sample and try to look for this pathogen, but I did not find, because at that time I have not so many experience. If I can do it right now, the most suitable sample that I should collect is not blood, but is bone marrow. Bone marrow is better. For example, in this case. So again, different pathogens have different characteristics. You need to understand it first so you can act properly. Okay. This is to emphasize surveillance and early detection is very important for the downstream process about prevention and management biosecurity. So, for example, this one is vector-borne disease. So, how to prevent? Vector-borne disease, how to prevent? For example, you may familiar with malaria or dengue. How to prevent? You may use repellent, right? Insect repellent or mosquito net, for example, right? Something like that. But this one, do you think mosquito net is good enough? No, not good enough, because they can escape or no, they can penetrate. Mosquito net, for example. Okay. So today I am going to share you about my experience on working with surveillance and early detection on wildlife. As you may know that many pathogens, they are hiding in wildlife animal that you may not realize. Many people try to link COVID with bat. Have you ever heard about that? But until now, I think nobody completely proved about that. But bat is a good example of animal, reservoir animal. Do you know why? Why bat is a good reservoir animal? Do you know why? Bat also has rabies. Do you know that? And many zoonotic disease. Do you know why bat is a good reservoir host that allow the pathogen to be with them, for example? Why the bat not kill the pathogen, for example? So bat is a mammalian. We are mammalian, right? But the bat immunity is evolved with the pathogen. They don't get sick. They don't have like a fever or something like that. Obviously, but actually I didn't follow them to everywhere. But they don't die, for example. They can live with the pathogen, and then when the time comes, the pathogen can go to you, for example. Sometimes. So this is there is a video that when we try to we capture the bat. So this is called the trap. The bats when they move, they use sonar, right? Sonar. They send the sound and then hear it. Their eye is not good. They prefer nighttime because their eye is not developed well, for example. So at night, when the sun set, they will go out, for example. And in here, when we try to capture them, we use the trap that look like this. We call harp trap. Harp is like a musical instrument. When the sound go to the trap, it pass. So the bat doesn't realize there is a trap. You understand what I mean? And then they fly directly to my trap. And when they go to the trap, and then they caught here and then drop into the bag, and we do the swab, collect blood sample, for example. I think this is the most non-lethal method that you can work with wildlife. 5 minutes left. Okay. And this is how to do it. Another example that of interest to us also, in this case, we are looking for malaria, TB, tuberculosis, hepatitis B, for example. But actually, I'm most focused on this parasite. So in Thailand, we have problem of overpopulation of the monkey. The authority that are dealing with this kind of problem, what they did in Thailand was they capture the monkey from a place that caused the problem to people. They capture the monkey and then they relocate them elsewhere, for example, to the Iceland, for example, that not so many people live, for example, or they relocate them to Myanmar border, for example, away from Thailand, for example. Let the monkey move to Myanmar, for example. So it really happened, but it's off record. I found some of the monkey have malaria with them, And unfortunately, those monkey already moved somewhere else. For example, maybe to Myanmar or somewhere else. Something like this. Okay, this is a method that we collect blood sample. This and that. This is about bat. Sorry. Bat can be like this. Some bat carry pathogen that cause zoonotic disease. For example, in this case, Borrelia. Are you familiar with this pathogen? Or Rickettsia, for example. These pathogen are tick-borne disease. And this is a tick. My friend actually, he was bitten by tick and he have this pathogen. My friend, he's a Japanese. He went to Africa. And he was bitten by not the bat, but bat tick, for example, and he get disease from that. 3 minutes left. Sorry. Okay. This is about you might not imagine that livestock animal also is a source of zoonotic disease. Also, in this case, it's a pathogen called Anaplasma praetis that normally you will find it in small animal, but sometimes you can find them also in the buffalo. In Thailand, we have buffalo, and buffalo can be a host of. You may not familiar. This is a tick, right? Fully engorged. Tick and mosquito are actually different. Mosquito, when they bite you, they bite you in a few minutes, taking your blood, just a few amount of blood. But when the tick bite you, they last maybe a day, for example, and can take a lot of blood from you. And of course, they can inject a lot of pathogen in your blood, for example. Okay, this is example that I already talked about. I will move. Because 1 minute left. In Southeast Asia, we have this kind of problem. That is mosquito-borne disease. We cannot eradicate malaria easily. Do you know why? Because they are hiding in the wildlife animal as well, right? You cannot kill all the monkey. There are so many species of monkey in the wild. You cannot kill all of them, right? So that's why it's very difficult to eradicate. So this is example from Thailand. This disease distribute a lot, and you may surprise. The mosquito can fly above the ground, sometimes 300 meters above the ground, and the wind will move them somewhere else. Meaning the distribution of mosquito-borne disease sometimes is far away. This is okay. Let's go. This is that's all. So people who work closely with animal are very important because you can prevent the spillover or transmission between pathogen in animal and people. If you know it, you can know how to manage, how to prevent. That's all of my time that I have. Okay.
Okay. Okay, that's all. Prof. Okay, thank you, Prof. Murakat, for your enlightening presentation. Now we will open the session for question and discussion. Please raise your hand if you have any question. Okay, and you can also type your question in the chat box if you are joining online. Okay, please raise your hand if you have any question. Okay, please.
Okay, good afternoon, everyone. My name is Ahmad Solihin. I'm from Jakarta. Thank you, Professor, for your presentations. I would like to ask about Professor Morakot, you are a veterinarian and you are work on surveillance with wildlife. In Thailand, I hear there are biosecurity law, by national biosecurity law in Thailand. Yeah. My question is, could you explain to us the rule of biosecurity law in Thailand for your working on surveillance in wildlife?
So there is a law and regulation that involve with practice in our country. If you are working in the university lab, there are several levels of biosecurity. For example, level 1, 2, 3, 4. The most strict level is number 4, right? Number 4 will be, for example, Ebola, for example. If you work with very highly dangerous or aerosol borne pathogen, for example. But most of the case, I work with BSL2 level, for example, and mostly I try to work with dead pathogen because we also afraid of transmission of or spillover of the pathogen. And but you asked about biosecurity. So and in the lab, there will be like audit for the biosecurity risk. There will be audit, for example, every year. And if you work with pathogen, you need to have like a license. You need to pass like some kind of training first to know about pathogen that you are working with. Something like that in Thailand.
Okay, thank you, Prof. Because in Indonesia, we know that we don't have biosecurity regulation or biosecurity law from now. Yeah. Okay, thank you, Prof.
Okay, thank you very much.
Okay, thank you. Is there any question, Prof? Other? Okay.
Good afternoon. Thanks, Prof. Morakot, for the amazing presentation. So I would like to ask, so in Indonesia, we have cities that have extreme markets. Like as a sample in North Sulawesi, like I know that there is a market that sells like bats or rats and even dogs to consume. And I also heard that in Thailand, even have that kind of extreme market that even has more extreme animals to consume. Like in your opinion, is that dangerous for the populations there? And do we have to stop that extreme market or just regulate that market or something like that? In your opinion?
Okay, actually, the law is not allowed to do that, but of course, it happened, right? It happened illegally. It happened. People have the wildlife trade. The authority try to control it, and like us, we also try to do the surveillance and then educate people, try not to do like that, for example. But sometimes you cannot stop people doing like that. So it's not only Thailand. Actually, I used to travel around Southeast Asia. It's similar. Even some people try to illegally export wildlife animal alive somewhere else. For example, turtle, snake, or many things. Not just to consume, actually.
Yeah, but I haven't heard. I ever asked locals there, like, how do you feel after eating bats? Because we know that bats is really dangerous, right? Like they have many pathogens in their body. Like they say, yeah, it's nice, it's delicious, and our locals friends has never been get sick because of that. Is that because of the environment of the bats, like they capture it from the nice forest, something like that, or what?
Maybe this is because how how you disinfect it. For example, you have snake and you put alcohol on the snake and then you drink, for example. This is the belief of many Southeast Asian. They eat wildlife animal, believing it will improve male strength or something like that. Is the belief, and the way they do may somehow prevent or kill the pathogen. For example, you put alcohol and then drink, for example, something like that. Or you cook. Even it may not enough, but some pathogen may not survive, for example.
Yeah, thank you.
Okay, is there any other question? Okay, right side.
Thank you for the opportunity, Professor. I'm Asha from Bali. I'm undergraduate medical student at second semester. I'm curious about the Japanese encephalitis virus. Like the risk factor is vector-borne disease, right?
Yes.
So I'm curious, like, why isn't there a specific treatment for the Japanese encephalitis yet? Can you explain why, from veterinary medicine point of view, like the mechanism process? Why isn't there a specific treatment for the this specific disease? Like, has the world already developed a treatment but hasn't been successful, or?
Okay. She asks about Japanese encephalitis virus. It is a mosquito-borne disease. It's caused by virus. Actually, to be honest, it's not my field actually, because I'm parasitologist. But what I heard is some people already develop vaccine actually, but the treatment may not so easily. Normally, virus infection is not really easy to deal with. Many viruses evolve quickly, right? Especially RNA virus. They have mutation rapidly, something like that. This is I try to answer, but to be honest, I'm not exactly in this field actually.
So much.
Okay, next question, please.
Okay. Hi, Prof. I'm Duala. So, in the last 3 days, I heard a lot about the importance of prevention in the zoonotic pathogen or disease. And from your presentation, I believe that you believe the importance of having a veterinarian, right? You guys are playing a very important role in the pace of preventing this disease. So I wonder, in the Indonesian context or maybe in Thailand context, because we have this livestock like everywhere, the farming and also the wildlife animal. So what is the ideal number of veterinarian? I mean, like the ratio of vet that we should have in Indonesia or in your country, for example, to prevent this disease from emerging from the very beginning.
You asking about what is the appropriate number of vet?
Yes, like the ratio, just the estimation.
The ratio.
Because in Indonesia, this is from what I observed, but of course it can be wrong. Like most of the fat student, they tend, after they graduate, they tend to work on this animal clinic for domestic animal. But from your presentation, like, it's really important to have more veterinarian to work on the wildlife animal case, and also to monitor the livestock farming in Indonesia.
To be honest, actually, I don't know what number should be enough, but I think important thing is effectiveness. The person who really work on that should be very capable, and actually vet itself may not enough. We need to work with the other disciplinary. For example, the disease involve a lot kind of party, actually, human, animal, environment, even people who work in the national park, for example, somehow they involve. But the number I don't know exactly.
Do you think at least like one village or one area should have like maybe at least one veterinarian or something like that?
Yeah, it's maybe good. If the government have enough budget or manpower.
One more thing, is it like vet medicine in Thailand is an attractive study or an attractive job for the young people there?
Oh, right now it's very attractive, but the payment is not that attractive.
That's why.
The work itself is very you find a lot of cute animal, for example, something like that.
Thank you.
Okay, we still have 4 minutes left. Maybe next question, please. Okay, maybe you first. Okay, please.
Thank you. Okay, Prof. My name is David. I'm from Palu. I have two questions. First is I think technically about the surveillance is the same concept to implement to surveillance in rodents. Do you have maybe you have the experience for that? The second question is I talk about the mollusk. Yeah. Okay.
Snail.
Yeah, snails. Now, how we control snails in the one side is the intermediate host for parasite, but in the one side in yesterday, Dr. Mala said it is the bioindicator of health ecosystem. Okay, thank you.
So rodent also can be reservoir for many zoonotic disease, actually. Actually, I'm working on rodent as well. But snail, for example, in Thailand, snail is an intermediate host of like liver fluke. I think northeast region of Thailand may be number one of liver fluke in human. And it also involved with liver cancer. But snail is not my expertise, actually. I don't know a lot about that. But it's somehow involved with parasite, but it's not my expertise.
Thank you.
Okay, thank you. Maybe last question.
Oh, thank you very much. So, Professor, my name is Putri. Maybe like the same like previous one, I would like to ask your opinion about the monkey. What's your opinion if we are killing a monkey by an old way like hunting and using the rifle? Is that the effective way to prevent the victor to getting to the human? Because we already have in some village in Indonesia, of course.
Hunting the monkey.
Yeah, by using the rifle, the gun.
Oh, this is you can debate about this issue the whole day. There will be no consensus about that because people who love animal will hunt you also.
It will cross animal welfare, something like that.
So I have no specific opinion on this.
Okay, thank you very much.
Okay, I think the time is up now. So thank you, Prof. Morakot, for sharing your expertise, also as well as our participant for listening, and also we can conclude that Prof. Morakot highlight the importance and of the integrated surveillance system and the vital role of a veterinarian and public health professional in translating surveillance into the preparedness of policy. I think thank you for you all of you once again. I think the time is up
Okay,
now. And
thank you for
Prof.
listening.
Morakot.
All right. Thank you, Professor Morakot and Dr. Yudi, for guiding us in this afternoon discussion. And unfortunately, Dr. Yudi and Professor Morakot has to leave this room after this. So before that, we would like to give our appreciation for both of you. So please, would you come forward? And for Dr. Edwin, please, as a representative of this organizing committee, to give the souvenir. Okay. Maybe, yeah. Foto. Okay, thank you, Dr. Edwin. And for now, we will move on to the next lecture session. But before that, I would like to remind all of you that yesterday's lesson, yesterday's slides, and yesterday's assignment, also quizzes, already uploaded at the LOX. So please make sure to check it regularly and completed the assignment within the due date. So without waiting any longer, I would like to introduce you to our last lecture session, and that will be led by, I believe everyone already know, our very first moderator at day one. So please welcome Dr. Edwin.
Okay. Hello everyone. Sorry, it's me again. Hope you don't get bored with me. So this is I think will be the last lecture in this room. How about that? Happy? Don't worry, because tomorrow we have another schedule. So at this session, we will see the reflection on what we have been through on the past Monday, Tuesday, Wednesday, 3 days, and the future of One Health. And this will be brought by Prof. Tri, the head of the task force of One Health. And I think we should give Prof. Tri a big welcome to give this reflection on what have we done and what will be done next on One Health issue. So let's give a warm welcome to Prof. Tri Wibawa.
Yeah, thank you. Good afternoon. Assalamualaikum warahmatullahi wabarakatuh. Ada slide-nya. So once again, you have very plain slide PowerPoint, and then I put it in this AI, and then they work like this. And then it is not mine. Actually, it is the AI of them, that one. Okay, that is for the disclaimer. So once again, after you are discussing, you are listening the lecture. So now I think this is the message, right? Integrating human, animal, and environment resilience. That is very important. Please, lanjut Pak. Okay. This is the law. This is how we going to act using One Health approach. Very small here. Yeah, the interconnectedness of domains. The health of one is intractably linked to the other, meaning that we now open our mind that if you are working in the animal side, whatever happened in your sectors must be connected with the other sectors. You are the one that is the primary trigger, or actually you are the result of something happen in the human side, yeah, or in environmental side, right? Like we cannot blame. Like it is going to be the responsible of the animal side, or for example, I'm working in the animal side. I'm saying that it's going to be responsible for the human side, right? Though maybe when we are talking about the in our sectors, like I'm myself in the human sectors, whatever the result will be in our case, right? I will talking about the cardiovascular disease now is increasing. The PPOK itu apa mas? COPD is increasing because of the pollution. There is a anthrax. Somebody die because of that, right? That is in my side. But of course, in animal side, sorry, bro, I did not recognize you. Sorry. And then in the animal side, of course, you should do the same thing, right? I have a wildlife that is really now threatening by the pollution of the plastic, right? The fish in the sea is becoming declining, and the result is because of they are starting to eat plastic, for example. Okay, and also the same thing, right? And now, this is the example that the interconnecting about this environmental challenge, AMR, emerging diseases, and pandemic preparedness, actually, it should be in our mind, right? You have to embrace everything. Like if we are not happy with the hantavirus pandemic, for example, just recently in the newspaper, right? Hantavirus, Nipah virus, another pandemic situation, emergency, public health emergency that might be happen in our countries. It should be we need to think that it is not all alone, right? And then these are the scope. We are not saying that the traditional paradigm is bad, no, but it's going to be better if we're using the One Health paradigm, right? This paradigm is new, and you already know that the scope and focus is different, operational model is different, and the solution design should be different also. It's going to be active instead of the reactive, for example. You have to forecast everything. If you have the deforestation process, then you will have spillover. If you have spillover, you may have pandemic threat, right? If you have many people, 9 billion people to be fed, then you need some plantation. And how can we have that plantation field if we are not going to cut the wood, right? Okay, because up to now the biotechnologies still did not and still not happen that not have capability to produce synthetic meat. So we have to plant the pig there. You have to plant the cow, cattle, chicken, whatever you want to eat, right? Otherwise, many people will suffering from starving because of that. Then it is going to be what circle that is end up to our health and animal health and also environmental health, right? And for example, Dr. Edwin is MD, right? He's also saying that I want to work with a plastic way because disposable is always the priority in the hospital. Is that correct?
Yeah, Prof.
Right. But you should think also that actually going to be so many garbage, plastic that is going to be, what do you call it, circulated among us. So there are different point of view, different of priority, and we have to make them in the middle, right? You are not compromise the health service that is need the disposable plastic for everything, but you need also to think how we're going to deal about that. Okay, and then remember, you are not alone. You are not alone. Dr. Edwin is not alone. Us is not alone, but other experts will be invited, right? Human health sectors, animal health sector, social science, anthropologists, behavioral experts, social scientists should be invited also. How do you able to solve this? Maybe economic expert also should be invited to share with us what will happen if we going to change our behavior, right? Okay. And the last thing here, I think, the check is there. Every what is it? Every cell is checked, meaning that there's no way that we're going to not included some part of us, right? So everybody have to contribute. Everybody have to contribute. The problem is how to communicate each other, right? Yeah, we need to use not our language, but we have to invent the common language for this animal, human, and environmental sector. Otherwise, they will not able to understand each other, right? Okay. Maybe I want to share like this. Leptospirosis. It is our problem in the human side, but it is also a problem in animal side, right? Okay. Then the animal expert saying that, oh, there is a rat, mice in the field. So they starting to eradicate, right? Mereka ditangkapi apa? They catch the rodent, right? They catch rodent, and then after that finish, because they think that this rodent is only the pest that is going to eat the rice plantation, and then the food will be the production will be decreasing. Finish. Okay, but in the human side, right? They think different. There are rodent in the rice field. They are not thinking about how the rodent will affect the food production, the rice production, but they think that they are factors of leptospirosis. Okay, so the same object, the different textile thinking is different. One saying that this rodent is a pest that is going to jeopardize the production of the food, of the rice, but another saying that it's going to be one of the, what do you call it, factors. And then if they talking about, if they discuss among them, then this animal sector, agricultural sector will talking to the human sector, saying that, hello, there are a lot of rodents. I have already catched all the rodent, but remember, the rodent may have pee in the soil. Please make sure there is no leptospirosis there. There is no leptospira there. So it is different thinking, right? And how can now we able to make these two people talking the same language in one problem? That's the way, that is the challenge among us actually. Okay. And then maybe the last thing is that I hope from this discussion in this class, summer class, from the different countries, then you will able to make a networking. Anybody working in education, working in research field, in community service, then please make a, what do you call it? Make a networking. And then I hope that maybe 2 years, 3 years, 5 years, or even 10 years after this, then you will become a pioneer in every place where you are working. I hope that the message is catched, and then after that you can develop other, and then maybe the next decade, maybe there's no fear about the One Health awareness. There's no fear about One Health is not accepted by many people, whatever, because we already know, we already understand. Then we think how we are working together, not convincing people, please think like this, right? But convincing people, please, now the time to working together. Okay. Then that's my slide. This is the end of my slide. But I'd like to, what do you call it? Hear from the student. What is your comment about this, or what is your experience? Meaning, here are theoretical thing, right? And please share among us now, from maybe from Bangladesh, from United States, Pakistan, Timor-Leste, whatever. Who will share first, please? Silakan. From Indonesia also, maybe.
Can anyone share? It's about feedback on our course here.
We understand about the theoretical thing. Maybe you find something that is different, or actually something else. Please, yeah.
Anyone? Okay.
Good afternoon. Thank you, Prof. Tri. My name is Nika. My background is from NGO. So I think this is very. There are a lot of lessons from this platform. As I understand, One Health as an approach, it's not really. I think we're still learning how to adapt, how to apply it in the context of Indonesia. I wonder how this application, since our stakeholder very fragmented between decision makers in these sectors, and they have a lot of conflicting in their interests. Since I'm working in the community base, I always thinking how the good way to start this approach. Can we start from the bottom up process, community from community level, or should we start from the top down? Because maybe the political willingness can be a good way to start and integrating the sectors. So do we have a lesson from other countries? Because maybe in the context of developing country like Indonesia, which we still struggling with corruption and things like this. They don't want. It's not so easily sitting together.
Right.
So how the best way? I'm still thinking how, because today, for example, Prof. Anis explaining about the data, which is still a lot of challenges in front. I'm questioning a lot of challenges he shared based on his experience working with Satu Sehat and yeah, the existing situation. But I don't hear a lot about how to improving this situation, because not only this in One Health approach, every time we talking about information system, it's always challenging in this part.
Yep.
Okay, thank you.
Yep. Thank you for sharing. Yeah. Yeah. If I'm not mistaken, there are 2 points, right? The first is how we going to start, right? And then the second is how we going to make people think about that, right? Okay. Maybe other student want to ask or any comment or the same thing happen in your country, maybe? Please, yeah. Before other people will will give comment about your insight. Yeah, I think the best way is oh, sorry, please.
Yeah. Okay, thank you, Prof, and good afternoon, everyone. I just want to give the information about One Health regulation. I think the government start to concern about One Health too, because from coordinating Ministry for Human Development and Cultural Affairs start to make or drafting the purpose Satu Sehat, purpose One Health, start or going to make a regulation about One Health. I think it is good for all of us, because for the government start to make a regulation, and we are here in the bottom, and all of academic or stakeholder start to spread One Health, semangat One Health apa ya? Yeah, One Health spiritnya. Okay, I think it's enough. Thank you.
Ya, ada kertas nggak Pak? Yeah. So yeah, I think that's true, right? The best way is, of course, from both sides, from the top. You're asking about top or it is going to be top down or bottom up, right? Yeah, I think it's the same thing. I think you can just parallelly doing that, like Pak Pasol, Pasol saying that government has, like, for example, for the antimicrobial resistance, the National Plan of Action, and also WHO Global Action, they mention about One Health approach, right? Meaning that the One Health has been recognized by the sorry, thank you, by the people that is on top there, right? They think that One Health is really important, and then from the bottom, we now learn. If we saying that we are in the bottom, right? So we learn about that, then we trying to catch the opportunity that is given by the top management in global and national to do the One Health approach. That's the first thing, right? We have to do bottom up and top down. But if you, like in Indonesia, if you are learning about how we have the strategic planning for the vector-borne disease, not even one word they mention about One Health, right? So it is something that is strange, because for dengue virus infection, it should be really related with the climate change, right? Climate change may change the habitat for the vectors. In this case, is a mosquito, right? But they are not thinking that this mosquito should be what do you call it? Should be there's something that is more integrated to make sure that they are not becoming the vector anymore, right? So in that case, we need to say to the government or whoever going to make decision that please remember, your problem cannot be solved by yourself, but you need to see this problem using the One Health approach. So it is going to be from bottom to up and from top to down. Okay, is that true? Whatever. The problem is how to start it, right? How to start that one. I hope that it's going to be maybe 5 years or 10 years after this, you're becoming the person that is able to make a decision, right? You will be in the center part of the government, for example, so you will facilitate us to make sure that everybody listening about this One Health problem, right? That's from Indonesia, right? What about from other country? Maybe from, please, if you have insight about the One Health.
Thank you, Professor.
Yeah.
To talking for the Palestine, the relation between the human, animal, and the environmental. There are many challenges facing Palestine because, you know, Professor, Palestine facing occupation, and there are no enough like, for example, if I want talking today, because we talking about the air and maybe air pollution increases. For example, the Palestine, the almost of the air or clean air that we can get it from Israel. So the large amount of the or a small amount we can get it from Israel, because that may increase the unclear or polluted air. This is one of the challenges that face us. This is according to the, for example, the air pollution also is the air. I mean the water pollution. The water pollution. Sorry. So another things I talking the challenges about the air pollution also, because you know almost of the almost of the country with Israel. So we live as a Palestinian in the small cities, and this is making traffic and a crowded city, and this is increase the air pollution by the air emissions from the cars and other things. So we cannot focus on Palestine because the political situation. But in for the Indonesian, I want to talking because I live here for 3 years, and
3 years
I
already.
see. Yeah, I see something weird here. Sometimes I see about the Indonesian habit. I want to talk about that because I see wastage of water in Indonesia. I see many people here like open taps and wastage a lot of water. And if he want like wudu and he open like taps and a lot of air wastage, and we know the wastage of water, it accommodate with the water pollutions, and this is make more burden on the government too. So I think to improve the One Health between the environmental, it not depend on the government. Also, it depend mainly on the awareness of the population. So many population do a lot of things without aware this is wrong or this is correct. We can most of people do something like it's normal. Most of people do like that, so I can do it without care. So I think it's very important to increase the aware, because I see the most dangerous in this plant is the human, not the plant or not the animals, because we see the air pollution from the human. If I can say about the water pollution, also the human. So we increase the damage for the One Health. So I think we need to more like instructions and government laws to increase the One Health for all. Thank you, Professor.
Yeah. So you just highlight that the problem is in the behavior of human, right?
Yeah, exactly.
That can affect everything.
Yeah.
We are wasting water. We are wasting everything, right?
Yeah, I see. Why I comment for that, because in Palestine we facing big challenges in water, and I see the people here like open the taps without care.
Sure.
Without
Okay.
care. Yeah.
Thank you to remind everybody
Thank you,
here,
Professor.
right? Because everything is centered in the human, right? Please.
Yeah, exactly.
The human behavior will affect everything, right? Is that your highlight? Okay, thank you very much.
Thank you.
From other country maybe? Ada yang lain dari? Is there any other person from Pakistan maybe, or Myanmar, or other countries? Maybe people that is also online before you, of course. From online. Yeah, silakan. Oh yeah, please share. Yeah, United States. It must be another story, right? Please, thank you.
Hello, everyone. I'm a current master's student at the Brown University in the United States. I guess the one thing I would like to add is that the US likes to specialize. So everyone is working for years in something that is so specific and so small. And I've actually never heard of One Health until now.
Oh, really?
And so in my master's program, I'm studying global health, but I also take classes on environmental health.
Right.
And I'm one of the very few students that is trying to branch out of my concentration and learn more. So I think that doing this course, I'm really grateful that I got to see how everything intersects, because I think it needs to spread to the US now. The US is guilty of thinking that they are. We're guilty of trying so hard. We spend 4 years in undergrad, and then if you want to do med school, it's another 4 years, and then another 4 years after that just to do one very narrow-minded thing, and you lose sight of everything else. So, quick story. Originally, I was going to go, well, maybe I still will. I did undergrad in neuroscience and psychobiology. And so I learned so much about the synapse and the action potential of, so it was such a specific, narrow concept of health that when I had graduated after 4 years, I thought to myself, what did I learn about healthcare? How can I go to med school if I know nothing about how to treat people and how to interact with people?
Right.
So that's why I'm doing my master's in public
Right.
health now.
And
But
now
yeah, I'm grateful for this. And I'm grateful for these perspectives and looking at how everything intersects because it is so important.
Yeah, thank you. So I think it is very interesting, right? So it doesn't mean that people have to like knowing everything, right? I mean, if you're in the med, then you have to learn about the synapse, potential action, of course, how to treat the human, right? But it doesn't mean that you have to learning about how to treat the cat, right? But at least we understand that somebody else really master in that part, so we can ask them to come in and please help us. That's the way we think, right? Because if you're still want to learning about to treat the cat, to treat the elephant, then it's going to be never-ending story for you, right? So please just make sure that you are mastering in your field, but you do understand people, other people, that is going to be helpful for us in that case, maybe, right? Is that correct?
Yeah, it's okay not to know everything. And it's a beautiful thing to be able to share with others and learn from them
Right.
to work together. So
Thank you. Yeah. Yeah. Thank you. Next, maybe. Silakan.
Well, actually, you kind of already answered my questions.
Right.
To me, One Health paradigm is quite promising, but I'm afraid. My concern is One Health sometimes sounds quite abstract
Abstract.
if it's not a literally topic. But like how to make it come true, to translate it into reality, I think we should propose not only concept or model, but really break down like the role distribution, who doing what, like social scientists or the exact scientists, microbiologists. And that's what lead me to think about the, like the knowledge management, the dashboard, the one that you mentioned before. Like you don't have to know everything, but I think we should learn each other to be able to speak to the same language.
Right.
We have to have like a kind of dashboard, a very good knowledge management system. So the people from the social scientists, like for example, me, myself, I learned a lot from this summer course in the last 3 days. The things that I don't usually hear every day in my field. And I learned a lot from this. And I really hope, I expect that folks from the like microbiologists or the doctor could also learn like our field, not to master, of course, our expertise or knowledge, but to learn each other, to have like a knowledge management system and knowledge sharing. I think it's really important for One Health. And like the breakdown of what can we do. So not only the concept and the model. I think that's
Thank
my
you.
thought.
That is more important, of course. How are we going to start to implement? How are we sure that we are not talking about a theoretical thing? Is that correct? Yeah. Okay. What I'm thinking is that actually the if you're talking about the implementation, then you need to jump to the problem itself, and then like for example, you're a social scientist, right? Yeah. My I have research with economic expert. I have research with a pharmacy and also public health. In what? In how to understand why people come to the pharmacy and asking to have antibiotic without prescription, right? And this is not my field, of course. This is I'm microbiologist like Dr. Redmond. And then what happened is that we need to understand why people asking antibiotic. And then we now know that actually people asking antibiotic is because they believe this antibiotic is able to cure everything, right? To cure everything, meaning that they have headache, then they think they need antibiotic. They have muscle ache, they think that it is need antibiotic. So they come to the pharmacist. Okay, then they starting to ask to the pharmacy. And then pharmacists think twice not to give to this person. Why? Because they think that if I refuse to give the antibiotic to these people, then this patient will go to another pharmacist. And then definitely they will give it. So why I'm so stubborn like this, right? Why I'm me the pharmacist, why I need to be stubborn not to give? Because other person will give. And then I will have no money anymore. I will not earn the money, right? But other people will, right? So many complicated thing, right? First, about the understanding of the antibiotic. Second, we're talking about the economic thing, right? And the other maybe many things, right? So in that case, Mas Edwin will not able to jump into to give intervention to that, right? Pharmacist doesn't have any clue how to educate the person. Maybe social scientists, anthropologists, or even economists, right? They need to come in and discuss about it because it is a problem. 70% antibiotic was dispensing from the pharmacy without prescription. It is true. Our result like that. And then behind that many complicated things like that. Okay. In Indonesia, we have pharmacy businessmen that have no pharmaceutical background at all. I mean, pure businessmen, right? So this is businessmen are having the pharmacies, and then what do you call it? Ahli apoteker apa? Pharmacists. Yeah. The pharmacists as a professional, they are working under the businessman, right? So though these pharmacists understand that the antibiotic dispensing without prescription will impact to the antimicrobial resistance, but they cannot refuse. Otherwise, these pharmacies or drugstore will collapse, right? And then if you're talking about the government, yeah, one's maybe thinking, why don't you just make this antibiotic like cocaine or sabu-sabu or other psychotropic drug? We just give very strict regulation, right? If you take antibiotic without prescription, then you will be punished, for example, right? We can do that. Can we? Can we? No, because people still need this antibiotic, right? How can you imagine that in the very remote area, right? Some one children or maybe people just have a fever and is infected by the bacteria. If they are not able to access the antibiotic, they will die maybe, right? So we cannot using the, what do you call it, the very tough regulation in that case, right? So many complicated, only one model, only one problem. So please, now you can just find other maybe 100 problem the same situation, right? Yeah. Okay. Okay. Other insight maybe from other countries, other problem. Jamnya sampai jam mana, Mas? Cukup? Yeah.
Three.
Or Prof, you want to comment something?
Thank you.
Pak Edwin want to comment something?
Me?
Yeah.
On this one online.
Oh, online. Yeah, please.
Or should I read it?
Gimana? Ada tulisannya?
Yeah, so writing.
Oh, sedang menulis.
Oh.
From University of Uganda. Okay.
Okay, there's a question from Esther Eunice Awari from Makerere University, Uganda. In Uganda, we have the National One Health platform already in existence. However, effective communication in the four ministry, that is health, environment, animal sector, and agriculture, is still a challenge. I believe if, as a country, we work on this, then we can easily protect the public from zoonotic disease and emergency of AMR. Thank you for training.
That is very nice to hear about that, right? So the platform is there. I think all the countries already like that, right? And like in Indonesia, just somebody just mentioning about the platform that is provided by the ministry. And here in Uganda, the same thing. The problem now is how to make sure it is work. It is not only in the work, only in the paper, right? It should be in the field in every cases. I think any other people that have the same situation in Uganda? Because we have actually, we know there is a regulation, there is a action plan, there is a people that is working there, but implementation is very, very hard because, yeah, so many problems. Yeah. Thank you for sharing from Uganda.
There's one more from the Philippines. Is it okay? One more from the Philippines.
Oh, the
Online.
Philippines. Yeah, please. From the Philippines, please. You can just open your mic if you don't mind. Yeah, please. Yeah. Joseph, please.
Hello, hello everyone.
Yeah.
Hi,
hello.
sorry.
I can hear you. Please.
Actually, we have the local initiative about the One Health, specifically for rabies. Yeah. So we formed the One Health Rabies program way back then, 2016, and we gathered together. We identified. We conducted stakeholder mapping, and out of this mapping, we identified the key stakeholders. We brought them together, and especially in rabies, we identified first the key players, just like the veterinary, human health, social services, and also we included the policymakers because we really believe that we cannot run a program effectively if it is not anchored in an ordinance. So we connected with the politicians, the policymakers, and alongside with it, we also introduced a digital platform. We called it as the Rabies Management Information System. So we've been doing the approach for more than a decade, and I guess it's doing well, the One Health Rabies program, and it started to be replicated to other cities and provinces in the country.
Thank you, Joseph, for sharing.
So I'm very
yeah,
thankful
please.
that I was able to participate in this training course to UGM and the organizers. Thank you very much for being part of this training course.
Yep. Thank you. Well, you're welcome, Joseph. Thank you for sharing. Is there any other comment from the audience here for Joseph, or the same situation will share? The rabies, yeah, rabies is problematic also in Indonesia. Part of us, of course, not in Jogja, but maybe in Bali or in other part. Yeah, yeah.
Professor, can I add a little?
Please, yeah.
Actually, we know pretty well that one of the limiting factor in every program is the funds. It's something to do with the financial aspect.
Yep.
So, what we have done is that we created also a program cost recovery scheme for the sustainability of the program. So we collected minimal fees from dog owners and also the animal bite patients. The very purpose is that to keep the program sustainable and not really relying much on the government funds.
Always being highlighted if you have One Health problem, pick One Health approach, because yeah, we do understand that maybe the priority is not there, right? I hope that from the next, maybe the priority will be there. So the politician and other governmental officer will
Actually, Professor, out of the funds we generated, we were able to expand our bite centers, and out of the funds, we were able to give salaries to our additional personnel, and so also the procurement of needed materials, equipment, computers, just like that one. Thank you.
Thank you for sharing. Yeah. Other comment maybe from other side. Okay, please open your mic. Satu lagi, one more from Nigeria. If it is possible, then please open your mic. Sharon. Good morning. Now we are in the morning. Yeah. Good morning. And we have made a word toward.
I don't think she will be open
Good
or put
morning.
mic. Hello.
Please, yeah.
Yeah, good morning. I'm Sharon Rumide from Nigeria. So in Nigeria, we've made efforts in implementing the One Health approach. We have different groups, different consortiums that are making efforts to, have this integration of these sectors. So one that I'm part of is the African One Health Disease Prevention Network, which is ADAPT, that is in about 7 countries in Africa. So what we do is to bring in experts from different fields, microbiology, public health, veterinary medicine, in order to have, to understand the transmission and how this sectors can work hand in hand. So what we do is to understand antimicrobial resistance. We deal mainly on antimicrobial resistance to understand how the cross transmission of AMR, and to know how we can strengthen the health system in Nigeria in order to prevent a sporadic outbreak of antimicrobial resistance. So we integrate the data from human, animal, and the environment in order to provide timely information that we can share, because our main goal is dissemination. so that we can share. And that makes me believe that having multi-sectorial collaboration and integrated surveillance will help in disease outbreak. It might not even be antimicrobial resistance. It could be any zoonotic disease. And this will provide effective response in order to deal with any health threats.
Thank you, Sharon. Yeah, the same situation in Nigeria, right? The zoonotic and AMR is the problematic, the same as in Indonesia also, and it is two of maybe three model or three sectors. Three topic that is usually becoming very fit for the One Health problem. Thank you for sharing, Sharon. Is there any question from the audience here? No. Okay, then because of time, maybe. Thank you. Yeah. Thank you. We need to wrap up this session. So please, Edwin. Yeah.
Okay, thank you very much, everyone, for feeding us some reflection on the One Health summer course of the past 3 days. I think there's a lot of, I cannot summarize all, but I think there's a lot of feedback, good feedbacks on each countries, even from Nigeria. You have ADAPT, African One Health Prevention Program, that's good. And even from feedback from the US, which has many people know about One Health, I suppose, and also from Indonesia, from the social science also, where knowledge management would be quite important for us also. And I think that all of this is a good feedback, right, Prof, on how we can handle One Health in the future. And I think this is the wrap up for this 3-day session. And I think thank you very much for holding this 3-day in this room, although it's quite cold, sorry. And yeah, and I think that we will give this one more chance to Prof. A big warm of applause. Thank you very much, Prof. And I will give back to the master of ceremony to continue on the program 2 days ahead. Thank you very much.
Right. Thank you, Dr. Edwin, for guiding us in this very last session of wrap up. And thank you, Professor Tri, for the incredible wrap up session. I hope this session will bring us a little bit hope to actually implement One Health into the reality, because I know it's not that easy and a lot of obstacles, I believe, but it not easy doesn't mean we cannot do that, right? So I hope everyone after this will bring a lot of hopeful to the future, about the interconnectedness of human, animal, and environmental health. So that concludes day 3 of One Health Summer Course 2026. Congratulations, everyone. Let's give us a big round of applause for ourselves and to all the speakers, moderators from day 1 until today, the last day of our learning session in this room. So over the past 3 days, we have gained insights from human, animal, wildlife, and environmental health perspective that reinforcing the importance of collaboration across sectors in addressing complex health challenges, of course. So on behalf of organizing committee, we really appreciate for your active engagement throughout the 3 days of learning and discussion from day 1 until day 3, and the thoughtful contribution throughout 3 days learning. And as your master of ceremony, I do apologize for any words from day 1 until day 3. So I would like to announce for today's agenda. For the next 2 days, we will take what we've learned into the field. So where we'll have the opportunity to observe One Health concepts in practice. And please dress comfortably, everyone, and properly for the field trip. maybe we can. I would like also to tell you about the group for the field trip. Yes, and for this group, there are a little bit adjustment because some of the red one is they're not here, but maybe for the white one, maybe for someone who from the online but now join us on site. So maybe you can please remember the group members, and maybe this is for the group presentation too, and for tomorrow's field trip. This is for the group 3 and 4. Maybe you can take a picture. And next, group 5 and group 6. Right, please remember your group member. So for tomorrow, please be here at 7:30 a.m. everyone, because at 8 a.m. we will depart to the location together. And also bring the t-shirt if you wish to exchange, because at the end of the field trip, you can exchange the t-shirt. Yeah, if you already list the ukuran, yeah, size, right? I'm sorry. Okay, that's all. Maybe Prof. Tri, any answer? Okay, thank you everyone. So don't forget to wear a comfortably dress, and see you tomorrow at 7:30 a.m.
What?